Hi, Robert. I'm Jamie. Nice to meet you, and thanks so much for being here.
Hi, nice to meet you too.
All right, looks like folks are coming in. Welcome, everyone. It is good to see you at long last. It's been a few months. I am Jamie Strauss-Clark, your facilitator, and this is the House Bill 1477 Crisis Response Improvement Strategy Committee meeting, the first one of 2023. So welcome all. We have very, very action-packed agenda, which I'm sure won't surprise you. So let's dive right into just our technology moment. Chloe, could you advance the slide, please? All right, so as a reminder, we have two slides here. The first is for our CRIS committee members and folks who are actively participating in today's meeting, so staff, and we also have some guests today. And I'm going to just remind everyone how we do our meetings so that we can make sure that we're not talking over each other and can hear well. So if you could click ahead, please, Chloe. First, a reminder, I'm going to ask everyone to keep your mute buttons on unless you are, unless it's your turn to speak, and that, of course, just minimizes the background noise and interference when other people are speaking. Click ahead, please. For CRIS committee members, staff, and our guests, when you're presenting or speaking today, if it's available to you, if you could have your videos on, I would appreciate that. It really does help with our engagement with each other, and it helps our guests follow who's talking and get to know you better. Of course, if you have bandwidth issues or you've just had enough of being on video this week, feel free to leave it off. If you could click ahead, please. We use the raise your hand function to make sure we're not talking over each other. So to find that, you click on the reactions button, pops up a window. So click ahead, please, Chloe. And you'll see raise your hand. I occasionally myself get mixed up with some of the emojis so in that button too. So all is forgiven if you get really excited and you press the wrong button. And of course, if, as I've said, always, if all else fails, feel free to wave your arms in the air and I will look out for you and try and call on you in the order in which I see you. Click ahead, please. For chat today, you should be able to reach me, Jamie Strauss-Clark, by chat. If you would prefer to share your question or your feedback or thought in writing rather than verbally, and I will periodically interrupt the flow of verbal comments and questions to fit in anything I'm seeing in the chat from CRIS committee members. The chat is for CRIS committee members today. Unfortunately, I can't monitor the chat for all of our guests in the audience. I'm going to ask us to just use the chat if you're a CRIS committee member today. If you have any technical difficulties, you can go in that chat and Brittany Thompson will be available to help you on any most technical difficulties related to Zoom, maybe not technical, but difficulties related to your own computer. Click ahead, please. Finally, if you would like to be able to see all of the CRIS or many of the CRIS committee members at once, you can click on that speaker view and change it to gallery view, and then you'll see more CRIS committee members. Click ahead, please. All right, this is our Zoom etiquette for our members of the public. Some of the same rules, if you could please keep your mics on mute unless you're speaking. I'm going to ask members of the public until we get to that public comment period at the end, if you could please keep your video cameras off today. Again, we usually have, today it looks like we have 76 participants. Sometimes we get over 100. It does just make it easier for us to facilitate directly with CRIS committee members if other folks keep your cameras off. The exception, of course, are folks who are guests stay presenting. We do have a number of folks presenting today. Click ahead, please. And then same reminder on that speaker versus gallery view. If you want to see more of our CRIS committee members at once, you can click on there and change it to gallery view. We do have 2 ASL interpreters with us today to support our guests who are hearing impaired. Melissa Shaw and Aaron Medlock will be providing ASL interpretation services. They will be switching off every 15 minutes and they should be pinned to your screen. You can switch to that gallery view and then see everybody if you don't need the support, but they are available to support you today. One last reminder to CRIS committee members, if you could try to remember to state your name and role or representation on the committee before you speak today, that will really, and also for staff members and presenters, that will really help our community members who are observing today to get to know you better and know who you are. All right, click ahead, please. We're going to dive into our welcome and introductions. Actually, I'm going to ask Chloe, sorry, if you could just take the presentation down for a moment. Thank you. We have some really special introductions today. First of all, at the suggestion of one of our wonderful steering committee members, we're going to be more expansive in how we do our welcomes and invite different CRIS committee members to offer the welcome each month. So today, Kashi Aurora is going to be offering our welcome, and then that will be followed by 3 of our wonderful Native and Strong Lifeline Tribal Crisis Counselors, Rosalie Lind, Heaven Arbuckle, and Robert Coberly, who are going to share some of their reflections of their experiences so far supporting their communities on the Native and Strong Lifeline. So let's start with Kashi, and then I'll turn it over to Rosalie, Heaven, and Robert. So Kashi?
Thank you. I'm Kashi Aurora, she, her pronouns. I work at Seattle Children's as the Mental and Behavioral Health Program Manager, and I sit on this CRIS committee as the representative from the state's Child and Youth Behavioral Health Work Group. So when I speak up, I'm often the squeaky wheel on what kids and families need in crisis response. And I have the privilege of welcoming you into the space today. So welcome. If you're new, an extra welcome to you. And as always, a huge welcome and thank you to members with lived experience. This work is made better because of your voices and your radical honesty, and we couldn't and shouldn't do it without you. So thank you. Jamie already mentioned this, but since we're a group that meets every month, this is our first meeting of 2023. So many people, myself included, find themselves doing a sort of refresh or reset at the beginning of a year, and I invite you to take an opportunity to do that here. It's 2023 and we're all recommitting to the work of redesigning and improving the crisis system we have in Washington. So if you've been with us for a bit, you know that this committee and the subcommittees and the teams behind this work have spent the past year or so laying a lot of the groundwork and foundation, and this year we get to continue to build on that. So I think we can expect the momentum and pace to pick up. And we've also been laying a foundation of relationship and the way that we've been approaching this work together, which is a good thing because we have a lot of big and challenging topics to take on in the year to come. And so I hope that that means we're not shying away from these topics, but rather approaching these conversations with curiosity and candor and in ways that are aligned with our own values and goals. And I think I can say with confidence that our shared value and goal here is we all want to see this crisis system in Washington state get better. We probably actually want it to not be necessary at all, but it is. So we need to have a crisis system that's responsive to people's needs and meets them where they are. So every time we meet, I think to myself, this is such an important time and moment to be having a conversation about crisis response. And every time we've met, it continues to feel more true. So thank you to each of you for being here and continuing to engage in these conversations. They are incredibly timely and deeply necessary always. So thank you and welcome. And Jamie, do I hand it back to you or directly to our Native and Strong?
Yeah, sure. I'll take it next and reintroduce. Thank you so much, Kashi. By the way, that was a beautiful introduction and actually a perfect opening to the content of today's meeting. But before we dive into that, and I also have 2 new CRIS committee members to introduce, but I'll leave you all excited for the next few minutes and we'll do that momentarily. First, I would love to welcome and thank Robert, Heaven, and Rosalie for being here today to share with us a few reflections from their experiences working on the Native and Strong Lifeline. So I'm not sure who of you would like to start. Looks like Heaven's ready to go.
Yeah, I'm happy to go first.
Thank you.
So I did receive questions. Would you like me to answer those?
Yes, if that works for you, whatever. I just everyone for context, I offered some prompt questions to help see if they're thinking about what they might share today, but please, Heaven, feel free to share whatever comes to mind about your experiences.
Perfect. So I did really like the prompt questions. It kind of gave me a direction on where to go with this. My name is Heaven Arbuckle. I work with the Native and Strong Lifeline. I am a shift lead. One of the questions that were asked in this prompt were, what are ways in which your identity is helping you better support Native people in crisis? My answer to that question was, as an Indigenous person who has suffered through their own traumas, trials, and tribulations, I found being empathetic is deeply rooted into who I am and what I want to show the world. So through my trials and tribulations, I would say I wasn't necessarily offered the same empathy that I would like to offer others in my community. I'm able to relate to the callers on this line, making it easier to kind of build a connection, give them the support that they need, and work for the solution. When I talk to these callers, I do my best to offer a safe place where no one feels judged. The next question that was in the prompt was, how has the experience of serving as a tribal crisis counselor changed or expanded your beliefs about crisis response? My answer to that question was, it's made me realize how critical it is to have crisis response. Too often we hear about police brutality, and I can't tell you how many times I've heard about police mistreating people with mental illness. And that's simply because they aren't educated on mental health. I myself was ignorant to what crisis response was until I started here with Native and Strong. And what I've learned is how beneficial, it is and why I support it. The last question was, what is one message you want the folks who are working on improving the crisis response system to hear today? My answer to that was, thank you for being who you are. Thank you for paving the pathway for people in crisis and people with mental illness. I think this is a great path for people to feel safe and heard who struggle with mental illness and are in crisis. So thank you all for listening to me. I appreciate it. And I'll pass it on to Robert.
All right, I got this. I'll answer the same questions too. It says, what are ways in which your identity is helping better support Native people? Being Native, for one, helps remove the biggest barrier. There already is trust and that understanding, knowing that you're talking with another Native person. My dad was put into boarding school, so his trauma became mine, and I was not taught how to express or communicate my thoughts or feelings. I have my own counselor, and I've been able to work through and to process my trauma, and I found a way to help other people, to guide them and to support them on their own path of, wellness. Two says, how has the experience of serving as a tribal crisis counselor changed or expanded my beliefs about crisis response? Growing up, I didn't know or see anything about crisis response. It wasn't not in my community, not in my reservation where I grew up. I knew nothing about it. The more I learn about it now with this work, I believe in it and I stand for it. And so it's just, three, same question is, what is the message I want you guys to hear? Is to be more aware of who you are serving, be open to the different ways of how you can handle a Native in crisis. What we need is sometimes different. It's important to look at someone in crisis from a different lens and be willing to adapt to what that person needs at that time. So that's what I got. Thank you.
Thank you so much, Heaven and Robert. Rosalie, would you like to share a few thoughts?
Yes, yeah, I was having some troubles with my camera, so I'm not able to turn it on, unfortunately. Oh, here we go. Hi, I'm Rosalie. I'm a tribal crisis counselor with the Native and Strong team, and I also answered the same questions we received in the email, and some ways in that my identity has helped me better support Native people is growing up in this culture has now given me the opportunity to share it with others on the line. Clients can call in and connect with a counselor who understands the history and trials that Native people have faced and still face to this day. Cultural representation is so important in these cases and can help us form a connection with these individuals. And how has the experience of serving as a tribal crisis counselor changed or expanded my beliefs? It's expanded my beliefs immensely by connecting with the different individuals that utilize the line, and just seeing the need for this type of response within our communities has really changed and helped me see like we need this so badly. It's so important to be able to be there for the people who call in and to support them and connect with them and just provide for them how we can in serving them. And one message that I want the folks who are working on improving the crisis response team to hear today is that we're just here to help the Native people and serve the community. We can connect with others on a cultural level with a deeper understanding of the issues that Native people face to this day. Thank you. Thank you so much for your time.
It is I who want to thank all three of you for, this is tremendous. Actually, I'm getting little messages from our CRIS committee members of appreciation for you coming and sharing. I think this is an incredibly meaningful. We're so grateful to you for the work that you do and for sharing it with us. And just really appreciate your time today. And actually that segues very, very nicely to introductions of two new CRIS committee members. The first is Marie Fallon, who is our new lived experience member. So welcome, Marie. Thank you so much for being here. We'll be reaching out to set up a onboarding kind of orientation call with you. We're so grateful that you're here. And second is Kim Mulsop, who's replacing Daria Farivar from Disability Rights Washington. And she's serving in the CRIS seat representing a social justice organization addressing police accountability and use of deadly force. So Kim, thank you also for being here. We did get to meet with Kim a few weeks ago. We'll do a little follow-up with you as well. But again, so thrilled to have you both on the CRIS committee. I'm going to walk you through the objectives for today's meeting and our agenda, and then of course catch you up on where we've been, where we are today, and where we're going. So I'm going to ask Chloe to put those slides back up on the screen. All right, so as I said, we'll start with grounding ourselves in where we've been, where we are now, and where we're going. You hopefully received the CRIS committee newsletter that was sent out last week. That is actually how we're going to do updates moving forward. I know we've historically had an agenda item that was focused on updates, but we're really trying to move these meetings toward more dialogue and engagement with each other and away from presenting. Today's meeting notwithstanding. So we are doing this newsletter, and then we'll use some time shortly to answer any clarifying questions you have about what's happening at the state agency level around crisis response improvement. Then we're going to be reviewing, discussing, and gaining clarity on how mobile crisis teams and co-response services are distributed regionally and by population. We'll take, I'll walk you through the actual timing, but we'll get a little break, and then we're going to gather your input to inform how we approach future discussions about expanding mobile crisis team services. So Kashi kind of alluded to that we have some very big, very important conversations, and in some of these cases, very challenging conversations. And today's meeting is setting the table for some of those. We'll confirm action items and next steps. And as of now, I don't have anyone who's requested to make public comment today. So it may be that we can buy a few extra minutes for our discussion at the end of the meeting. If you could advance the slide, please, Chloe. So here's the timing. We're about to move into our personal story. And then at 3:40, from someone with lived experience. And then at 3:40, we're going to spend a few minutes doing Q&A with our agency folks. Any clarifying questions you have coming out of that newsletter that you should have received last week. At 4 o'clock, we will go into our discussion, reviewing and gaining clarity on regional system gaps. We're aiming for taking a 10-minute break at 4:40. And then at 4:50, we'll return. And this is going to be when we move into discussion, full discussion, providing insight to inform our future discussions about expanding mobile crisis teams. Then we'll move to action items and next steps and public comment period. As I said, if I don't hear from anyone wanting to make a comment today, I might just use those 10 minutes to expand our discussion time. Next slide, please. All right, I want to nest us in our work in 2023, and I want to ground us in that based on your feedback. So this slide here, which I know is probably too small for some of you to read on your screen, so don't worry, we'll make sure you get a copy of the slide deck. This slide actually represents the feedback that we heard from you at the end of last year, grouped by our areas of work. And the reason we put this up here is we want to make sure that you have this first before we move into how our work plan for 2023 has been shaping up. So this, again, we'll make sure you get this information again later, but this is based on feedback we received from you at the end of last year. Next slide, please. All right, so nesting where we were and where we're going. Today's meeting is focused on setting the table for some of our future discussions about expanding mobile crisis teams. And actually, I'm characterizing today's meeting as part one of a two-part discussion, focused on, in particular, the role of co-response in mobile crisis teams. I know that that was an important topic last year, and we really didn't have the opportunity to do it justice. So today we're going to be focusing on providing some of the information that you requested at the end of the last year to help inform that discussion. And then our intent is to devote the March meeting to actually rolling up our sleeves and talking about the role of co-responders in mobile crisis response. You'll see on here, it also says focus on youth systems. I want to acknowledge that probably requires its very own meeting at least. Don't worry, Kashi. We are working simultaneously, and I know that Representative Orwell has put forth a bill that's intended to help extend the timeline here and give us more time to have these important discussions. So our hope is that we can use the March meeting to focus on the role of co-responders and dedicate another meeting to focus on the youth system. But until we get the green light to expand our timeline, that's why you're seeing this very aggressive timeline here. In April, our intent is to continue discussing crisis system gaps, this time with a focus on a place to go, so crisis stabilization. In May, we will be looking to you to provide input to inform crisis system goals and measures. In June, is when we began the conversation about recommending expanded or new crisis system services needed to meet those goals, and continue those conversations in July, also talking about costs. Actually, July and August. August, recommendations for crisis response system oversight. So we're going to be building on those recommendations. And then in September, reviewing our draft policy recommendations as a foundation for the final report. And then November and of course December will follow the same pattern we followed in previous years, where you provide input on the final report in both the November and December meetings. We ran out of space on the slides, so that's why it only says November. Could you announce the slide one more time? I think I might have covered everything. Oh yes, let me just throw this up here. We have some CRIS and steering committee meeting dates coming up. You'll see those on the calendar here, and I believe those invitations will be going out to you. I just wanted to give you a heads up on those. A couple more notes before we dive into our personal story. I want to acknowledge a couple of things before we move into our meeting today. And Chloe, if you don't mind taking the slides down, I think great, thank you. First, I want to acknowledge that we are, as I said, we are going to be talking about the role of co-responders in mobile crisis response. Today, we're setting up for that discussion by making sure that you get as much information as you've asked for, or some of the information you've asked for, as much as is available to help set you up for that discussion in March. But also acknowledge that there are different models of mobile crisis response, many of which have been operating in Washington State for a long time. And so we're going to be discussing all of these models, not any one particular model. I also want to acknowledge that it certainly seems to me, and I've heard from others saying this too, that it seems like every day there's a news story that is alarming, distressing, frightening about interactions, for example, of police with people who are experiencing crisis. And it is creating, I think, distress for many of you in the CRIS Committee, as well as many folks in who are observing today. And I want to assure everyone that everyone who's been involved in planning today's meeting is committed to approaching these conversations with both candor and sensitivity. But please do take care of yourselves as you move forward in these conversations. Please let me, your facilitator, know what I can do to support both candid and candid conversations that you feel like you can participate in. That's very important to all of us. I think that's it for my preamble. Let me just make sure I haven't missed anything important. No, I think that's it. And we're at time here. So I am going to turn it over to Bipasha Mukherjee, who's going to introduce our guest who's sharing her personal story today. Bipasha.
Thanks, Jamie. Hello, everyone. My name is Bipasha, and I serve on CRIS and at steering as a person with lived experience. Without this being about competing on who has a greater trauma, which doesn't serve us at all, I do want to say last week when I talked with Jerry, I felt my heart going still. I don't have the words to describe the multiple complex emotions I was feeling while I was wondering, how is she who she is? How does she do what she does? I think you'll understand when you hear her story, but let me share with you what Jerry wanted you all to know about her. Jerry Clark has lived in Washington State since 1995, moving here shortly before her son Calvin was born. She raised her son and stepdaughter while teaching yoga and dance throughout Southwest Washington and Portland for about 20 years. When her son became ill with severe bipolar disorder, she began advocacy work with NAMI and took a job at PAVE, helping families whose children need special education services. Her work with PAVE ends March 17th, a day before the 4th anniversary of Calvin's suicide death. On April 1st, she begins a new job as Family Resource and Advocacy Manager for the National Nonprofit Treatment Advocacy Center, TAC. TAC is narrowly focused on treatment access, policies, and laws that prioritize appropriate care for people with the most severe and disabling mental illness conditions. Jerry is happy to be a grandma to 2 little boys and surfs the Oregon coast on a pink and white longboard whenever possible. I just want you all to know that HMA will be sharing some information about her story in the chat, some web links, so please feel free to click on them. And Jerry is open to reaching out to anyone who wants to talk to her. But here's Jerry. Oh, that's all I'll say. Thank you, Jerry.
Thank you so much, Bipasha. And I do have a PowerPoint, so do I have capacity to share my screen? I need that.
Brittany or Chloe, can you set Jerry up for that? Welcome, Jerry. Thank you for being here.
Yeah, thank you. And, before I shift to my presentation, Facebook this morning reminded me that 10 years ago today, my son won a district championship in extemporaneous speaking. He was well on his way to becoming an extraordinary public speaker in the political realm. So I found that auspicious that I had this on my calendar today. All right, it looks like it's going to let me share my screen, and I'm hoping technology supports my notes here as I go into presentation mode. So again, thank you so much for offering me this opportunity to speak. I started a grassroots movement called MOMI, Mothers of the Mentally Ill, while my son was still living. It was in key moments on the phone with crisis responders that I knew my son Calvin would probably not survive. My honor student son was kind, loving, and generous before he lost his mind to a brain-based disease. When he was very unwell, crisis responders told me they could not help unless he hurt himself, became medically incapacitated, committed a crime, or hurt me. I'm going to cover those 4 topics today. Overall, I want to make clear that a crisis call never changed my family's trajectory toward the better and consistently made things worse. I want to make sure that sharing my story here today leads to action and is not treated as a soundbite. I spent many hours preparing these remarks for you, and I do appreciate your attention. For my son's type of illness and his level of acuity, dangerousness and crime were requirements for response. We were trapped by our son's illness with doors marked tragedy as the only exits. Each time I called crisis, I got a person trying to convince me that I was mistaken and ours wasn't actually a crisis at all. His right to be ill was defended, not his right to appropriate care and treatment. First point, hurt himself. At the moment he stepped off a hotel roof and plunged to his death, my son met the elusive criteria for care. His final act was to prove himself suicidal. The crisis system is not built to prevent harm, but instead requires harm. My son was too smart to fail at suicide. So that's how 4 years of crises ended. He killed himself March 18th of 2019, not long after this picture in Seattle was taken. 2, become medically incapacitated. I remember one crisis call with acute detail. In deep psychosis with severe paranoia, my son was afraid to drink or eat for a couple days because he believed we were trying to poison him. A crisis counselor arrogantly explained how only a medical doctor could determine grave disability, possible only if my son voluntarily went to an emergency department and requested an examination. If he were an early stage death, she explained, he might be found gravely disabled and thus hospitalized. I've been told since that the information was inaccurate. Oops, too late. Regardless, I know our state's grave disability statute is poorly understood and not used well to save lives. Training is badly needed. Getting an evaluation from an elusive designated crisis responder is an enigma. Families like mine know the crisis system is mostly designed to keep us at bay. It feels like a DCR's primary job is to find ways to justify that our very ill loved ones are actually perfectly fine. 3, commit a crime. Every crisis responder I ever spoke to defended my son's right to be ill. They defended his psychosis over protecting health and safety, his, ours, and the public's. I knew it would destroy him to hurt me in a psychotic rage, but seeing what was obvious got me nowhere. Responders were a stuck record on this point. It is not illegal to be psychotic. That's how most of my crisis calls ended. That and telling me that tricking my son into committing a crime might help the situation. My son got sick enough so that jail happened, and that made everything worse. The obvious ethical thing to do when someone is dangerously disconnected from reality is to treat them, not leave them to suffer or cause harm. But our medical legal system is not built to act ethically. Dangerousness is prioritized. When that standard is finally met, there's almost always a crime. A person's relationships are broken, employment opportunities are dead on arrival, and their level of brain damage and trauma makes it nearly impossible to ever recover. That's why we have almost 900 people in Washington state jails waiting almost a year for competency restoration beds at one of our state hospitals. The status quo will keep making this worse unless we radically change our crisis response system. Let's get to my fourth point. Hurt me. The crisis system needs an entirely different protocol when a family member calls because a loved one is disconnected from reality due to psychosis and has symptoms of illness that disable their brain from seeing its illness or understanding why treatment is essential. This is the area of your work that I most want to influence. Too few people understand severe mental illness and what it's like to live with it in your home. Before he was ill, my son always treated me with love and respect. When he was lost in his disordered mind, Calvin lashed out at me in bizarre and vicious ways. I now know that he had a symptom called anosognosia, which meant his brain was unable to see its illness or recognize the need for treatment. No provider or crisis responder ever taught me about this symptom and how difficult it would make my attempts to communicate with my son or get him appropriate care. I talk with families all the time who know that getting hurt themselves might finally get their loved one with anosognosia a ticket into treatment. I know 3 women who have been nearly killed by their sons with schizophrenia. None of those young men ever threatened to hurt anyone until they experienced untreated psychosis. Their actions were a result of florid, untreated psychosis. 2 weeks ago, a teacher in Tacoma was killed by her son in a way that fulfilled my longtime worst fear. The young man stabbed his mom to death. He told police he had to, quote, pop the robot's head off, end quote. A similar incident in 2019 happened in Port Angeles when a young man bludgeoned to death a longtime family friend in a state of untreated psychosis. He demonstrated for a judge that he was defending himself against, quote, threatening behavior, which when he demonstrated looked like the offer of a hug to anyone in their right mind. We should all be terrified that the status quo is designed for outcomes like this. Both families tried desperately to get mental health help for their loved ones before these tragedies. I tried so hard to get my son help in that narrow window of dangerousness that opened before it came super likely that he would hurt me. My husband refused to let me be injured, and that part of our story is something too painful for me to discuss anymore. I'm glad I'm still here and I'm able to do this work. Some people will accuse me of furthering stigma by sharing this true information. From my vantage point, stigma is made worse by people whose unmet needs lead to horrific harm. We need to treat these illnesses to stop the harm, not throw a cloak over the truth. Your job is to fix what happens when a crisis is underway. Your work cannot improve outcomes unless it's part of a system reboot. The most evidence-based treatment for people with anosognosia and symptoms of psychosis is assisted outpatient treatment. Our state has made baby steps toward AOT development, but I'm concerned that AOT might prove itself a failure if it's not rolled out with the robust resources necessary for it to operate correctly. The National Nonprofit Treatment Advocacy Center has an AOT implementation team ready and willing to help our state in this endeavor, and I am offering my help too. I added this slide today. This is my friend Eric Smith. Eric is featured in the People magazine that's coming out at the end of this week. He talks about his anosognosia and how in a delusional state, he threatened to kill his mother. The opening line to the article is this: 12 years ago, Eric Smith believed he was a secret agent who needed to kill his mother to save the world. Within the article, there's a picture of Eric and his mom, happily together now. I've told Eric many times that I wish my son's story included the upward spiral of his, but Calvin didn't get assisted outpatient treatment. Eric experienced crisis after crisis, with providers telling his parents that he would need to get arrested to get help. His downward spiral was finally stopped when a particular crisis led him into AOT. Texas had that option. I'm pretty sure some of you are thinking that AOT is outside the scope of your work on this committee. You are wrong. If the 988 rollout doesn't include AOT as part of its toolkit, it will keep failing people like my son and Eric. Here's how I believe you can connect 988 funds to AOT. SAMHSA is awarding $250 million in community mental health services block grants as part of the $800 million allotted through the Bipartisan Safer Communities Act to get the 988 Lifeline up and running. Adults with serious mental illness are targeted population for these grants, which have flexibility to support new and existing programs. The grants are designed to support the most evidence-based programs, positioning AOT as a logical use of these funds. A certified community behavioral health clinic can include AOT and is an excellent model for growing a functional behavioral health infrastructure, which these SAMHSA grants encourage. Using 988 funds for AOT makes logical sense because AOT is a protocol that can turn a crisis into a moment of change in the trajectory of someone's severe mental illness. It's the most compassionate and ethical option to help someone recover control over their mind and their life. During his illness, my son was frequently discharged from a hospital with a less restrictive order. No crisis responder ever cared that Calvin had an LRO. Dangerousness was required with or without an LRO, and jail was always encouraged over treatment. I support our state's call to develop crisis response centers. A CRC could be a safe landing place for a person to be evaluated and considered for assisted outpatient treatment. A referral to AOT could stop the revolving door of failed hospitalizations, crisis after crisis, incarcerations, and suicide attempts. Let's make sure 988 means a better future for others like my son, Eric, and the two men facing lives in prison for killing loved ones because their brains weren't working correctly, and the thousands more who need better help. So please reach out to me and let me help your work. The status quo is causing tragedies. Let's focus on evidence-based ways to prevent tragedy. Thank you for your time.
Well, maybe some of you now understand my complex response when I spoke to Jerry. Thank you again, Jerry, for sharing your lived experience, but beyond that, challenging us to dig deep and do the hard and thoughtful work in planning this behavioral health response build out. and for your options for solutions, including money, which the behavioral health system needs. You also wanted us to know that in your new role as an employee of the Treatment Advocacy Center, you plan to focus on new resources for families trying to navigate a disordered system and advocacy towards treatment policies that acknowledge the symptom of anosognosia. You want society to understand that the ethical thing to do when someone is dangerously disconnected from reality is to treat them, not leave them to suffer on their own. Expanding access to AOT is a priority. Another priority you have is to share your idea for a federal law to incentivize most evidence-based care protocols for the most vulnerable individuals. You're happy to speak to anyone interested about your work and priorities, and you can be reached through an email link on your website, MOMI, that's how you say it, -wa.org, or directly at jerry.clark@momi, that's MOMI-wa.org. That's also going to be posted on the chat or website. Thank you again, Jerry.
Thank you.
As ever, all I can do here is echo what Vipasha said. Jerry, thank you so much. My chat box is being flooded with notes of appreciation from our CRIS committee members for both your sharing your story today and also giving us concrete things that we can think about and do, and also for offering to support this work moving forward. So thank you for all of those things and for being here today and for kicking off our 2023 discussion so importantly and beautifully. Okay, so with that, we're going to move into our Q&A for agencies. Again, there was a newsletter that went out, I think it was on the 8th, so a week ago today, that provided you with updates of happenings at the state agencies. So we wanted to pause now and see if you have questions for Carrie, Michelle. I think there was something in there from Jane and the Office of the Insurance Commissioner. Any clarifying questions that folks have about what you read in that newsletter. And please use the raise your hand button and I'll call on you as I see, or feel free to send the question in the chat and I'll read it. Darcy.
Hi, this is actually for Jane. I'm curious, I know that you're working on the expanded coverage, but I don't think that it applies to self-insured plans. Is that right? And if that's right, do you know how many lives are there within self-insured plans in Washington?
Okay, so actually, while the work that we're doing is with the insurers in Washington State, after we included the provision in our state law that included behavioral health crisis services as emergency services, we in the Kennedy Forum together reached out to the Department of Labor to ask the Department of Labor to sort of interpret the Federal No Surprises Act to allow states to include in their definition of emergency services, behavioral health crisis services. And they did do that in a frequently asked questions document that they sent out. I can try to find it and put it in the chat. And what that does mean is that because Washington State took the option that was provided by the federal agencies in their interpretation of the No Surprises Act, their interpretation is limited to facilities, unfortunately. So self-funded group health plans do need to cover behavioral health crisis services that are provided in facilities. So crisis triage facilities, crisis stabilization, evaluation and treatment. But because of a limitation of the use of the term facility in federal law, we can't extend the coverage of mobile crisis response teams. So it does a significant portion of the provision in our state law does apply to self-funded plans.
And do you know how many people are covered under self-funded plans?
Yeah, so of the about 4 million people who get their coverage through an employer-sponsored health plan in Washington State, I think about 60% of those folks are enrolled in self-funded health plans. So the connection that we have that helps is that a lot of the health insurers in Washington State also administer self-funded health plans. So at least they can, when they're administering self-funded health plans, there's a connection there to understand. But I think your point is well taken, that we need to do a better job working with employer associations, et cetera, to get the word out about the application of that provision. We, under our Balanced Billing Protection Act, self-funded group health plans can opt in to participate in our law. And we think one of the reasons that they were doing that was in part because of this behavioral health provision in our law. So I know this is really wonky statutory interpretation stuff, so I'm happy to try to provide some information in writing to the HMA team to share out.
That would be great, Jane, if you don't mind. Darcy, did that cover what you were asking?
Yes, thanks, Jane.
Okay. Thanks, Jane. Jen.
Hello. Thanks so much for doing the newsletter. I really appreciate it. I know that's a lot of work. Question, I just wanted to ask if other people, I have not been able to read it because I didn't know about it. And then I looked in my inbox and didn't see it. And so sometimes that happens with mass mailings where it's labeled something that you can't find it under, or it goes into spam. So just kind of wondering if others have read it or found it in their inboxes. And then just wondering if it could be posted, if it's not already. I didn't look on the CRIS website, but if it could be posted in advance of the CRIS meetings on the HCA CRIS page as well, just so if in case that happens, and if we know it's coming, that's just awesome. Just wanted to put that out there.
Jamie, Nicola can probably say a couple things about the vehicle.
Nicola, you want to jump in here?
Sure. Yeah. The newsletter we included with the meeting materials for this meeting. So it came out as part of the communication last week with the agenda and materials attached.
Oh, okay, that's cool. So it's not coming out in your email.
Exactly. It's part of a separate communication. Part of that sort of single communication. And our thinking was to include the newsletter with, every meeting in advance, to include the newsletter so that you all have that a week in advance to review and bring questions to the CRIS meeting.
Awesome. Thank you.
Yeah.
And Jen, just acknowledging you as the reason that we started the newsletter. This was your idea last year. So thank you for helping us to be more efficient.
I'm really sorry I missed it. My apologies. Thank you for doing it.
You're not alone, Jen. I see a few notes in my chat box that a few CRIS committee members missed it as the attachment. So apologies to everyone that we didn't alert you more to what was going to be coming to you in this change in our approach. For future meetings, as Nicholas said, this is our intent to get this out along with the agenda at least a week in advance of the meeting. So as you're preparing for upcoming CRIS meetings, please know that you'll be seeing in your inbox a single email with the agenda and the newsletter. So thank you for raising that, Jen. Any other clarifying questions for our state agencies? Okay, sounds like that newsletter did what we needed to do. So with that, and of course, if you do think of other questions during the course of our discussions today, please feel free to send them in the chat and I'll make sure they get to our state agency folks. That puts us back sort of on schedule here. So let's move forward with our next segment in our agenda. This is going to start with a series of presentations, and then I'll facilitate some question and answer before we take our break, and then we'll come back for discussion. As I've mentioned a few times today, this segment, our objective is to review, discuss, and gain clarity on how mobile crisis teams and co-response services are distributed regionally and by population. And today we're going to focus really on mobile crisis response. So just a little bit of context for you. As part of House Bill 1477, HCA needs a work plan to expand mobile crisis response teams in each region, including specialized teams to respond to the unique needs of youth, Alaska Native and American Indian populations, LGBTQ+ youth, and geriatric populations. We will be asking next month for a CRIS input on the composition of mobile crisis teams, including the role of co-responders, and then hopefully at a future discussion subsequent to that, youth services. So the information being presented today to set you up for those conversations is in response to request from CRIS, I think at our December and possibly our November meetings, for a deeper understanding of service gaps by region in preparation to provide your input on the composition of mobile crisis response teams. Do need to acknowledge that the data that is being presented today is imperfect. It is the best available data, and we aim to continue to provide the best available data as it becomes available. But there are going to be some limitations, and Betsy's going to speak momentarily about limitations before we turn it over to Matt Gower from HCA. You will also be hearing from Jen Stuber after Matt Gower, who's going to be presenting her research on co-response models in Washington State. So that's going to be the composition of our presentations today before we move into discussion. I'm going to turn it over to Betsy now.
Thanks, Jamie. I'm Betsy Jones with Health Management Associates. For those who don't know me, I'm leading the effort on behalf of Health Management Associates under contract with the Behavioral Health Institute to support the work of the CRIS, including the steering committee, the CRIS committee, and subcommittees as we meet the requirements under House Bill 1477. If we could forward this slide, Chloe, I'm just going to talk for a minute about limitations in the data that we have to frame this next conversation. And for all of you, when Jamie moves into the facilitation of some questions, for all of you to be thinking about in terms of where we need to go to better understand system gaps, goals, and resources that will be needed in the future. This information was mostly provided in our progress report that was submitted to the governor and the legislature last January, and it came from our state agency partners, as well as feedback that we got from you in the community. So first, in terms of data, demographic information is imperfect. There's no centralized location to track data on individuals receiving mobile crisis response services to identify and monitor disparities in mobile crisis response, DCR, and first responder crisis response. So in all of those categories, we don't have breakdowns to really understand what's underneath some of that roll-up data. Children and adolescents are undercounted, and we likely don't have a good picture of youth population needs, particularly for those under 13 years old. That was a fairly large topic of discussion last year on the CRIS committee, and we need to acknowledge where we have gaps in data related to children and adolescents. Mobile crisis response team staffing is limited in terms of what we understand related to team staff composition. Current data is based on a survey of our BHASO partners at a point in time. The HCA team is working on improving that information, but we don't have a complete picture of what staffing looks like in terms of team composition at present. We don't have a centralized mechanism to track mobile crisis response data across all payers and the uninsured. Efforts are underway through the Behavioral Health Data System, the BHDS, at the moment, but we don't have perfect data in that regard. We are lacking consistency in coding for mobile teams, DCR ITA investigations, and crisis stabilization services among BHASOs, Medicaid MCOs, and commercial MCOs. Response times are not available in one tracking system in terms of mobile crisis response. We have information from BHASOs in terms of time to reach. It's not consistently provided, but we do have some information from the BHASOs, but we don't have a roll-up at the statewide level. And results are reported results are limited to either under 2 hours or greater than 2, but under 24 hours. So you see that we don't have the granularity that we need to understand response times. We need more specific data there to get to more precise response time information by region, including within 60 minutes. And then utilization. As we know, we've had some significant challenges understanding historical data about utilization, and that limits analysis. We saw that in our first year of operation as we tried to drill down into Medicaid data. Utilization outside of the BHASO system is not captured in the data. So for example, within the criminal justice system. So all of those other serving sectors don't roll into the information that we currently see either. So we have some significant limitations in the data that we wanted to frame for you and set the context for what you're going to hear next, and that we will be discussing at greater length in today and in future meetings. Thanks, Jamie.
Thanks, Betsy. And now I'm going to turn it over to Matt, who's going to present his work on excuse me, on the crisis response model and how mobile crisis response is distributed throughout Washington State and by the regions. So Matt.
Thank you, Jamie. And thank you to the members of the CRIS Committee and interested people in the public. Thank you for giving me the opportunity to speak to you guys on this fine February day. My name is Matthew Gower. I'm the Crisis System Team Lead here at the Healthcare Authority. My role is to help implement the services, operations, and infrastructure kind of around someone to talk to. So someone to respond and a place to go are kind of in my team's purview. I wanted to talk to you today about how we are doing our planning for mobile crisis response, how we've identified gaps, and how we are kind of approaching modeling how to roll them out. So just to start off, just kind of ground us in mobile crisis response. I think the last time we really talked about this model was back in July. And if your brain is like mine, that was a couple decades ago. So this mobile crisis response is based on SAMHSA's best practices. It's adapted and operated through WAC 246-341-0910. Always feel like a robot saying WAC numbers or RCWs. But the idea here is to offer community-based interventions wherever the person in crisis is. So at home, at work, at school, wherever the person is, we come to you is the goal there. It utilizes a two-person team to enhance safety and engagement by giving different personalities, different approaches, different viewpoints to graft onto and work through the crisis. It also adds that safety element to the team so that they have a partner that can kind of look around and assess while they're there. And the idea here is to support emergency department and justice system diversion. So having a behavioral health response to a behavioral health crisis mitigates the chance of somebody ending up in prison or an unnecessary emergency department admission. Their teams are multidisciplinary. So in our model, we use a professional, or we often refer to him as a clinician, and a certified peer counselor. We recognize that certified peer counselors in crisis aren't available everywhere, but for planning purposes, this is what we are using. But we always use a two-person model just to ensure people are outreaching in pairs. And then another point on here is these services by mobile crisis are always voluntary. And I'll get a little bit more into that later, but these services are meant to come out at a person's request and work with the person under fully voluntary terms. Next slide. So in our model, for these planning purposes, this is what we have made up in a team. This is what we consider kind of the core functions of mobile crisis. There's that clinician that I alluded to earlier. It's made up of a mental health professional, which is a credential for typically a master's level clinician and above. Then there's the mental health care provider, which is often a non-licensed master's level clinician, bachelor's level clinician, and even AA level with some experience. And then we also sometimes include substance use disorder professionals for people who are doing SUD outreaches, although that's more of a kind of a specialty role in some of our bigger teams. And then we also have the peer support who provides that empathetic viewpoint of somebody who's been there and can meet a person where they're at. And then of course, all teams need somebody to help coordinate and provide supervision and support. So we include a supervisor as our core team. And then as we're working to build out the MRSS model and provide more stabilization and follow-up for our mobile crisis teams, we've also included stabilization team, not used in this particular planning exercise, but just want to highlight them, of a clinician and a peer and possibly a care coordinator to help follow up and reduce the load on the people doing the initial response. Next slide. So what we don't consider part of our mobile crisis response are other services that are very important in the crisis continuum. Again, our goal is to put out a voluntary behavioral health response to people in crisis. So for that reason, in our planning purposes, we did not include co-responder models. We do not include designated crisis responders who can do ITA investigations. And we don't include recovery navigators, which are starting to kind of move more and more into our crisis system. We didn't include DCRs because we want these services to be voluntary and we want to be able to provide somebody an option before an ITA investigation is necessary. We also want to respect the role that DCRs have. They have a very unique role. And we want to make them available for when that role is needed. And the same goes for co-responders. We want to be able to provide the mental health first approach and use co-responders in those situations where they are necessary and most effective. And then other important crisis providers that we don't necessarily consider in the mobile crisis model is foundation community support providers, forensic navigators, peer bridgers, and other social service teams that work around or with a person in crisis. Peer bridgers are typically after an inpatient stay. Forensic navigators could be helping somebody in competency restoration. So they may interact with our crisis system, but we don't consider them part of our mobile crisis model for our planning purposes. Next slide. So a little bit about that planning process. What we used is a Crisis Now calculator. It's a calculator that's created by a partnership of a lot of different national entities. RI International, SAMHSA, NASHBID, which is the National Association of Mental Health Personnel. I never remember that. It's an acronym that's over 4. I'm not going to remember it, but it's basically the leaders from around the country in mental health for their states. Represented here from our state by Carrie Waterland. They got together, they created the Crisis Now program out of SAMHSA's best practices, and then they created this calculator to help states with planning purposes. The inputs for this are gross population, prevalence of mental illness in a particular area, mostly county or state level, and then possible drive times throughout the area. This gives us the number of mobile crisis teams needed to respond based on the set of conditions. It also gives us information on the number of stabilization beds and chairs, as well as how much cost savings could come if we implement this model. Next slide. So we use the outputs from that to give us kind of a gross number of mobile crisis teams we would need in a region to respond to a crisis within SAMHSA's best practice timeframe of 1 hour. And then we used the FTE method. So as we've talked about before on here, defining a mobile crisis team is very difficult because a team in King County, as they defined it, can be very large, sometimes 20 people, multiple supervisors, whereas a team in, let's say, Yakima could be a lot smaller, maybe 10 or 11, and even in our smaller counties could be just 2 or 3 DCRs rotating shifts. So we wanted to try to create a standard to kind of measure everything by. So we use the 2 FTEs, that is a dyad of a clinician and a peer. For planning purposes, again, want to emphasize, we know that there's kind of a shortage of peers out there, but we at least want to provide at least 2 clinicians on every outreach. And this allows us to flex the size of need based on the service area and allows us to flexibility for coverage and composition. So some areas may not need 24/7 response. They may just need on-call at night or something along that line. Then we surveyed our BHASOs about their mobile crisis teams at a county level and asked about the current staffing levels, number of openings, and number of DCRs working as mobile crisis teams. And we compared all of these with the mobile crisis or the Crisis Now calculator, and we got a nice fancy report out of that. Next slide. So we were able to put this on there with a map. The circles indicate where a mobile crisis team is based. The size of the circle represents how much FTEs. This is still somewhat a work in progress. That's why we're not sharing it as actively, as there needs to be some peer review with our regions to make sure we capture the information correctly. But this at least gives us an idea of where everything is located by county. We can go down to a city level and up to a regional level as well, but just gave us a good kind of visual of everything. So on the next slide here, sorry to keep you working there, Jamie. Again, give us an idea of how much we have by region, how much staff we have versus how much staff we need to make things work. And some of these numbers will be a little bit off as some of the responses were incomplete. You'll notice Great Rivers is not on here. We did not get a good response from there. So the information from those regions may not be as accurate. That's why we're not sharing this report very broadly. But this gives us kind of a planning tool, and we can also go a little bit deeper. If you can share the next slide.
Actually, Matt, sorry, go ahead.
Yeah, could you go back, Matt, and just explain the gray versus the blue?
Oh, yeah, absolutely.
Yeah, thank you.
Yeah, so the gray is the FTEs that we have, and the blue is the FTEs that we need. And so the full bar is everything we have, and it just shows the ratio of how much we have versus how much we need to fully operate a team for that 1 hour response time in each region.
And Matt, so sorry to interrupt your flow. You're doing such a great job cruising through all this material. But we also had a question from a CRIS committee member asking if you could just briefly unpack the FTE method so they understand what you mean by that.
Yeah, as I mentioned before, the FTE method is where we just assume 2 people as kind of a unit of measurement. So that FTE method is we broke down teams into how many 2-person units would be needed to fulfill that goal.
So that's just a summary for, like, instead of the complexity of an actual team, you're just summarizing a team as 2 full-time people.
Yep. And letting whatever in the future that looks like work for whatever provider region wants to actually call a team. Yes, thank you, Buck.
Matt, sorry, does FTE stand for something specific?
In the lived experience subcommittee, I was terrible about explaining my acronyms. Yes, it means full-time employee. So it's the estimating method for a person working 40 hours a week.
Thank you. I figured, but I didn't know how to translate that. Thank you.
No, thank you for holding me to that to be more clear.
Matt, we've got lots of people supporting us on tracking the acronym. So you keep going. And folks, if you hear an acronym that you don't know, feel free to send me a chat and I'll work on getting an answer for you in the meantime. Okay, Matt, keep going. I've got some questions I'll ask you when we get to the clarifying questions, but we're good for now. All
right. So yeah, next slide. Actually, yeah, so we could show how things look on the county level, but I'm going to pick on Thurston Mason here. Because they have their team really based in one county and operate, or that's not really fair. Their team operates in both counties. And so when we spit out the raw data, it gives us a breakdown of what's needed in Mason, what's needed in Thurston, and it kind of distorts those numbers. So there's some gaps in this is what I want to highlight, but it is one of the better methods we have to estimating how many employees we will need to make this work. So not necessarily working by team, but the idea of working how many actual bodies will we need to make this work. And the next slide is the same results by county, but for our smaller counties, because obviously King County throws the scale off a little bit, so we would have never been able to see Lincoln or Ferry County. And then again, just want to highlight that not all the data in this survey is complete. So, and then next slide. Yeah, all right. So that leads us to the known limitations of this method. This is so far the best method we've come up with. The Crisis Now calculator, though, only has that gross population information. It does not have age or special population, so it won't really necessarily help us drill down into ensuring that we're providing services to youth, older adults, our LGBT community, or improving services where there is deserts for those populations. It also uses averages, not necessarily fluctuations. So it could be possible that on one day you have 100 crisis response calls and another day you have 5. I've never seen something quite that extreme, but that's just a good example. And then also counties often share resources. Another good county grouping to pick on is the Tri-Cities in Benton and Franklin County, where their teams often go across those borders. And we can't really estimate that in the Crisis Now calculator. This FTE method may also underestimate coverage needs. We're guessing 2 people at all times, but with fluctuations, with on-call, we can't necessarily capture that. And it also doesn't consider those ancillary needs like follow-ups and ongoing support. It's only that initial 1-hour response time. And then we also geography. There are parts of our state, as you guys are very aware of, is very mountainous and during certain times of the year, harder to pass through than others. The Crisis Now calculator attempts at that, but it does not capture it very well. And then we're also only considering SAMHSA's best practice, which is the national model. It doesn't necessarily factor in state of Washington or any pending legislation. And one other piece that I'm going to invite my coworker Sherry on here to talk about is that youth and how we're going to try to go about planning for youth teams. So, Sherry, if you're on.
Yeah, thank you, Matt. My name is Sherry Wiley, and I work here at the Healthcare Authority on the Crisis Systems team, and I'm the Youth Mobile Crisis Team Administrator for the state. And so I'm going to talk to you briefly about Youth Mobile Crisis. The best practice model is mobile response and stabilization services, or MRSS. And as you can see here in the youth crisis continuum, it looks very similar to the adult crisis continuum. But you might notice instead of a place to go, it's called a safe place to be. And this is because youth teams can both respond to the initial crisis and they can provide a separate but connected in-home stabilization phase. While some youth meet the acuity and can benefit from facility-based care, the majority can be kept safe at home with the support of MRSS teams in place. The youth teams are designed to meet a sense of urgency with urgency and provide developmentally appropriate interventions and intervene at key interruption points. An example of this is when schools identify a youth who might have symptoms or is participating in self-harm or has a risk to self. They can call in a youth team who can respond to the school and get an intervention in place and work with the parent instead of sending them to the emergency department. Next slide. This map shows the youth teams that are currently funded in the state. And so the bottom line is broken down into the 10 regions in the state. And those 10 regions are contracted through HCA to provide crisis services. So each region has so many counties in it. So you can see the counties are broken down on the bottom line. And then the columns represent where the youth teams have been funded or where they currently exist. So the blue columns are the youth teams that existed already in the state. The light green columns are youth teams that we sent out funding for through that proviso funding that we had last year. And that funding was intended to stand up at least one youth and one adult team in each of the 10 regions of the state. We also have a system of care grant in 2 regions, and that's in Pierce and Spokane. And so you see a dark green column that supports rollout of MRSS teams in those 2 counties only. And then based on population needs, you can see that the purple column would suggest where we might want to invest in youth teams sooner than later. And then the orange line running across the top is the youth population per 75,000 kids in each county. And so as we invest in these teams and roll them out, we can start with the population centers, and then we can, as we get more data, it will help inform where we want to invest in more youth teams. But the goal is to ensure that all youth have access to these teams across the state. And I want to thank you for the opportunity to speak to you today. And I think I'm going to give it back to you, Jamie.
Thank you, Sherry. Thank you, Matt. Great work there. We do have some clarifying questions from our CRIS committee members, and I think it might make sense, rather than waiting until all the presentations are done, that we pause here and ask those questions before we turn it over to Jen Stuber to present her research. So first question, Matt, is how is the need calculated? Are we talking about vacant FTEs or need as in what it takes to respond to this region?
Yeah, thank you. Great question. It's total number needed to respond within 1 hour. So our formula took into account existing FTEs, including open positions that are funded and they're just trying to staff. And then we pulled the numbers from the Crisis Now calculator and subtracted the current numbers with those openings, and that gave us how much more we will need to get to that 1 hour response time based on the Crisis Now calculator.
Great, thanks, Matt. And then is the FTE needed broken down by youth versus adult teams, or just FTE needed overall?
It's mostly adult. It's a gross population, so it just takes into account how many people are living there and does not break it down by age. So we've taken it as adult, basically.
Okay, and then this is a comment from Kimberly Hendrickson with Kitsap County. She noticed that the numbers listed for her county appear to be a combination of designated crisis responders and non-designated crisis responders. And she mentioned it sounds like it conflicts with the definition of mobile crisis team and would be great to exclude DCRs. Do you have any thoughts on that, Matt? Or is that just feedback to file away?
Yeah, just to highlight that these numbers have not been peer reviewed by our regions quite yet. It was based on a survey. And so some of the information in there may not be 100% correct. So that's why we're not publicly releasing it yet. But yes, you are correct. DCRs would not be part of the MCR model.
Okay, so there'll be some vetting before these become fully public. Thank you for that. Is there one mental health professional supervisor per each clinician and peer provider dyad? How many teams are the MHP supervisors supporting?
We haven't really come up with a full definition on that. We have our working one has been about 5 dyads per 1 supervisor, just to try to limit the amount of burnout on the supervisor. But different teams have different standards. Like I said, what's defined as a team in some regions may include multiple supervisors to cover, day shift, night shift, and all that. But that's kind of the rough ratio that we have been using for an MHP.
Okay, and that probably segues very nicely to a question from Darcy. Did the calculation factor for number of teams needed for 24/7 coverage?
Yes.
Okay, easy answer there. Kashi.
Can I ask a quick question, especially, given the personal story that was shared at the beginning, the models that you both have talked through, I heard you stress that they are voluntary. Is there a best practice outlined in the SAMHSA model about when there's a handoff or a connection or an invocation of involuntary service?
I don't remember one in the SAMHSA best practice, but the way we are approaching it is mobile crisis would be the first offering. And then if they're unable to help, then we would bring in the DCRs, which is one of the reasons we didn't want to include them in the mobile crisis, is so that they are there as an ability to respond when needed. The mobile crisis team would be able to stay with the individual until that happened or help transport them to a more secure place, depending on the situation.
Yeah, so mobile crisis gets to be sort of the first response, and then there would be sort of a triage to a DCR. Do we know if there's consistency across teams in that, or I'm thinking about youth as well as adults?
Consistency is not really a thing in our state, and that's one thing we're working on. We're creating a best practice guide that'll be published in July that we're going to start building out more and more of those consistencies statewide. One of our better strengths in our state is we have a very regional approach, and so regions do everything a little bit different based on the resources they have.
Thank you for that answer. Maybe just for the record for Chris, I think this would be something really important to look at about how those decisions are made about when it goes from the voluntary mobile service to the involuntary, because that's if that's not defined, that's rife for bias and things falling through the cracks. And so not a knock on HCA, just wanting to own that in the lack of conversation or process that exists, that can be a dangerous setup for providers to not have the resources they need to make those connections. So thank you for presenting on this, and thank you for taking the question.
And you're absolutely right. Absolutely.
Thanks for raising that, Kashi, and we'll make a note of that. Actually, we had another CRIS committee member send a chat asking questions about voluntary versus involuntary. So we will follow up with all of you on that. A couple more questions in the chat here. Can I clarify why I heard what I heard? This information and data will be shared with ASOs to validate and comment?
If this report moves along in its process, yes, definitely.
And
we want to make sure if we get a good picture from you guys before we share it broadly.
Thanks, Matt. And then how many teams total, how many FTEs total, and what percentage of the need is currently being met as per the definition?
I don't have a full roll-up on it, but I would say we're probably about 40% of total for that 1 hour response time. So we have 40% of the staff. And the need is probably most concentrated in our 2 largest counties and in our rural areas.
Thanks, Matt. Any final questions from CRIS committee members before we move to Jen Stuber's research? Kimberly.
Thank you so much. I don't have a question, but just a statement as a CRIS committee member. The slide that was showed before Matt's presentation about the lack of common metrics across the state was highly disturbing to me. Anything that I can do as a CRIS committee member to encourage the HCA, I think, or DOH or any other state agency to act on and enforce consistent standards so we have a better sense of what's happening where would be something I'd very strongly support. Thank you.
Thank you, Kimberly, for sharing that reaction to the earlier slide. Dylan.
Yeah, I think I might have missed this, but that 1 hour response, is this a 1 hour response in person on site, or are we looking at telehealth?
In person, yeah. In person is
within 1 hour. We're hoping to get one of these mobile response teams. Got it.
Yeah, and one of the obvious limitations is, of course, geography, where it may be impossible to get from one place to another in an hour in certain parts of the state.
Of course.
But yeah.
Thanks.
Thanks, Dylan. Any other questions for Matt or Sherry? Okay, again, if you think of other questions, please put them in the chat and we'll make sure we try to get to them. And with that, I would like to turn it over to Dr. Jen Stuber, who's going to present her research on co-response programs in Washington State. Jen.
Hi, thanks so much for that presentation, Matt. I really appreciate all the work you all are doing at HCA. My name is Jen Stuber. As JB said, my pronouns are she and her, and I am a professor at the University of Washington. But first and foremost, I consider myself an advocate because I'm a person with lived experience, and I have actively care for people with lived experience. And so I'm presenting on co-response programs in Washington State. And so why are we covering this topic in our meeting when co-response programs are typically dispatched by 911 or brought into a behavioral health crisis situation from referrals from first responder agencies like fire or police? Well, that's because Kim Hendrickson here, who is also a CRIS member like myself, asked me about a year ago what I consider supporting CROA, the Co-Responder Outreach Alliance, in kind of helping standardize, professionalize, get a sense on what's actually happening in terms of co-response in the state. And thought to myself, well, do I want to do that? I'm really interested in 988. But it's been honestly the opportunity of a lifetime to really learn in real time, what's happening in the field on the ground in response to behavioral health crises across our state. I also want to acknowledge Reed Klein, who's going to help me present some of these slides. He's largely responsible for how beautiful they are. And so he's going to kind of chime in at various points in this presentation. I also want to acknowledge that we have a certain idea about what co-response is in this state. And I'm not sure that idea like actually matches the reality of what people who are doing this work think co-response is. So I really want to make sure that's clear. The definition we'll share in a minute, but what I want to acknowledge, if you go back for a second, is that people are very, very concerned about, in this committee and more broadly in this field and this work, I'd even say law enforcement would say this about law enforcement responding to behavioral health crisis. I mean, law enforcement, I can honestly say, is very concerned about that as well. And so really what I see co-response as being about, and this is why I took up the mantle of doing this research, and I'm saying research with a small r, not a big R, this is applied research. I took up this mantle because I am extremely interested in figuring out there's going to be situations when law enforcement gets called out. If you call 911, law enforcement is going to get called out in certain situations. Like, for example, Jerry's story, which I was so bravely shared. And so what co-response is about is trying to optimize a response. It's not the George Floyd story. It's not the Tyree Nichols story, because those are not co-responders that are going out in those situations. And honestly, if there were co-responders going out, co-response teams going out in lieu of those kinds of responses, I think we would be in a different place in this country. So I just want to acknowledge that there is a lot of, I think, misunderstanding about what co-response is and a need for it, but also it's part of an ecosystem that needs to be much more robust in Washington state. And I think we've had co-response develop a lot in this state in response to the fact that we haven't had an adequately funded behavioral health crisis system until now. And that's the work we're all doing together. Next slide. So co-response program, here's a definition that we have as a state. This is not formalized in statute as of yet, but its co-response programs are partnerships between first responders, including law enforcement, fire, EMS, or EMS agencies, and human service professionals, such as behavioral health professionals, social workers, community health workers, peer support. Co-response programs respond to behavioral health related calls and calls involving people with complex medical conditions. This is very unique about co-response. They don't just respond to behavioral health, they respond to complex medical conditions. They can provide in the moment crisis response, and also, but more importantly, they provide a lot of follow-up services. And their ultimate goal is to really connect people with appropriate community resources to reduce the use of emergency services. And so this is a definition that was written collaboratively by co-response programs across Washington state. But I want to say, point out again, co-response does not equal law enforcement going into the field by themselves. That is not what co-response is. It can be law enforcement going into the field with a mental health professional. It could also be a fire EMS going into the field with a mental health professional. It could also be a paramedic going into the field with a mental health professional. So I think if we're going to have a conversation about how co-response could fit, we have to really understand the diversity of models and the complexity of the models. And I just want to say, it's not like Washington just came up with this broader definition. There's an organization called the International Co-Response Alliance, or ICRA, that defines co-response in this kind of broad way. So I think we have to get this is nationally, not just in our state. Like, we have to really understand what co-response is and what it isn't. And I think we're not going to have productive conversations as a group unless we kind of wrap our heads around that. Next slide. So just to level set again, because this was really hard for me at first when I was kind of learning the complexity of our system. So what Matt was talking about in his earlier presentation are mobile crisis teams, and they're typically dispatched by crisis call centers. Our regional crisis lines are they're the ones that actually dispatch the mobile crisis teams in our state. Not even currently the 988 line does not dispatch the mobile crisis teams. And the co-response teams are typically dispatched by 911 or requested by fire and police. So in a sense, we have these two systems, right? There's the the 988 system that we're seeking to design that is very much working in partnership in some ways, but not quite yet, with the regional crisis lines. That's kind of what we're striving for. And then we've got the 911 emergency response system, which is sending out co-response. And right now, one of the big goals of this group ultimately is to have some of the 911 calls that are coming in be really handled by 988. That there's a less acute response, and we don't need the co-response teams. But just to say that we have these kind of siloed systems, but people in crisis don't experience crisis that way. So it is very important that we understand that there's an ecosystem that's needed, there's collaboration that's needed, that needs to be organized. So why will we always need co-response? Well, and I just need to say, as part of our ecosystem, and we can talk about how much of MCTs versus co-response, et cetera, but why will we always need it? Well, because there's some calls that mobile crisis teams won't respond to, those involving a safety risk. I would say that sometimes we want co-response if there's a safety risk. I'd rather have co-response than just police alone, if it's possible, and not always possible. If there are medical issues, complex medical issues, they're going to send out, we want to have co-response teams. If we need within an hour is not fast enough, as amazing and aspirational as that is, we're not meeting that need, but we sometimes need even a quicker response, and that you get through activating currently in this state 911. So those are the reasons we need co-response. Also, this is most MCTs don't currently do transport, and so that is a really big problem, that we have mobile crisis teams that won't do the transport piece, or can't do, or aren't equipped currently to do the transport piece. So you inevitably have to bring in a first responder. So we need to talk about how do we address some of those issues. Co-response teams often do provide transport. And then first response agencies, they have this co-response is in large part come about because we need a way to respond to people who are frequently calling 911. And 911 is an emergency response system, not a way to respond to behavioral health needs that are of a more chronic nature. And so we need to be where there's no access to care. So we need to be able to have a response to that that's in the field. So I just want to point out, and hopefully this will lay this to rest in this group, because I don't think we've had a chance to really talk about it. It's not an either or approach. Like, we need an ecosystem of mobile crisis teams and co-response teams. And so, yeah, that's that slide. Okay, so now I'm going to turn it over to Reed, who is going to just chat a little bit about the little R research we've been doing, and this is in response to Senate Bill 5644 that passed last session, that really called on the UW to basically do this landscape analysis needs assessment, which is going to see, as you'll see, going to look a lot like what Matt was presenting related to mobile crisis teams. Reed, are you on?
I'm on. Thanks, Jen. Hi, everybody. As Jen mentioned, my name's Reed Klein, pronouns he, him. I work at the UW School of Social Work, supporting the landscape analysis of co-response programs in Washington State. And you see on this slide, just a kind of a brief overview of what we've done so far and what we're currently in the process of doing. But so far, the main thrust of our analysis has been developing an online survey, which we distributed to law enforcement, fire department, and other local government agencies in fall of 2022. And based off of the listservs that we were using and collaborating with on behalf of WASPIC, Association of Washington Cities, Washington State Fire Chiefs Association, and others, we think we got close to 100% participation in that survey. And once we got those responses, we cleaned them up, reviewed the responses with an expert on co-response to identify any inconsistencies. And then we began to do a little bit of analysis on those survey results, as well as geocoding the locations of the programs and mapping them, which I'll show in a second. In addition to the basic survey data, we wanted to integrate other publicly available data sources to learn more about the programs and provide context to how the programs are operating. So we used census data, as well as some mapping data on legislative districts, BHASO regions, and tribal lands to understand better where co-response programs were operating and where they were not. In addition to the survey work, we're also currently in the process of doing key informant interviews with co-responders, and are hoping to write up those results in the coming months. Next.
Reed, can I just kind of
Please
point
do.
out one thing? So we said we're going to do this kind of interactively. So the key informant interviews aren't just for fun, for big R research. In fact, they're not. We're really trying to deeply understand like what is happening in the field around crisis response, and when co-response is being utilized in the field, and potentially where could we have an alternative like a mobile crisis team. We're also doing ride-alongs, which I can tell you honestly, I did not understand this work until I started riding with people and seeing the heartbreaking stories that are out there related to our crisis system and how difficult this work is. But we're doing those also to really kind of provide a really deep picture to the legislature about, what are the needs in terms of the community and what are the needs in terms of the teams in order to continue to do this work and to do it as well as we can.
Thanks, Jen. Jamie, could you go next slide? Awesome. So speaking a little bit to what we've learned so far from our survey, what exactly are the services that our co-responders are providing? And we kind of lump those into three buckets: crisis prevention, crisis intervention, and crisis follow-up. We found that 95% of our surveyed programs reported offering crisis prevention services. So these are, transportation, connecting individuals to community resources such as food banks, doing outreach among unsheltered individuals. Almost as many programs, 90%, reported doing crisis intervention services. So that's things like doing crisis de-escalation on the scene or doing safety planning with folks in active crisis. And then we found that over half of programs also offer crisis follow-up services. So that's, you can think of like doing case management, after receiving a referral from a first responder, or, doing follow-up with an individual leaving discharge or leaving the hospital. And so the kind of main takeaway for us so far in looking at all these different services that co-responders are providing is, speaking to that point Jen made earlier, that it's a complex service model, but it's also a very flexible one that meets individuals in a lot of different settings. Next slide. So here's that map that I had mentioned, and I'll provide a link after I've gone through my slides to the active map that we have online that folks can interact with. But you can see here that we've identified roughly 60 co-response programs throughout the state. Almost 2/3 of those are affiliated with law enforcement agencies, but almost 1/3 are also affiliated with fire departments. And you can see really the major takeaway being that the programs are kind of disproportionately located in the I-5 corridor, the Puget Sound Basin region, and that large swaths of the state, not just rural areas, but other population dense areas like Yakima and the Tri-Cities area actually do not have co-response programs. Next slide.
Hey, Reed, can you go back 1 second? Just talk about the purple.
Sure. Yeah, so that the purple there is population density. So deeper gradation or deeper tones of purple indicating higher population density per census block group, which is the most granular level of population data that we could get. And so you see there in the Tri-Cities area between Benton and Franklin counties that we see deeper shades of purple indicating higher population regions that with no corresponding blue, red, or turquoise or gray dot, indicating no co-response program down there, similar for Yakima. Jen, do you want to add anything else?
No, I just think this kind of mapping is really important to understanding like where we need to prioritize.
Yeah, and that's the next slide, I think also speaks to that. We We wanted to also, look at where programs stood relative to BHASO regions, as Matt and Sherry alluded to in their presentation. The crisis system's largely built around the BHASO regions, and we see, looking at this map, that some regions obviously might have a lower amount of co-response programs than would be warranted. Looking particularly at the Greater Columbia region. Next slide. And then the last thing I wanted to share with you folks was just looking a bit at the program staff. So in our survey, we asked, what are the types of professionals that you employ, and what's the FTE of each of those individuals? So you see a breakdown here among all programs, all 60 or so that responded, of the percent of FTE. Thanks, Matt, for clearing the way on that acronym for us already. The percent of FTE of that position among all programs. So you see disproportionately, co-response programs are staffed by human services professionals, such as mental health clinicians or peer specialists, and that it's less than a quarter of co-response programs are actually law enforcement or firefighters. And so I think that speaks at least to one of the myths, which is that this is like a primarily law enforcement based program, when in fact it's overwhelmingly a human service and behavioral health oriented program. Looking at just the average in the total FTE, we see as of our latest survey results, about 435 total people working, or full-time positions working in co-response in our state, with an average of about eight people per team, or 8 full-time people per team. But there's a lot of variation there. Some teams only employing 1 person, some up to 20 or more. The median FTE among all teams is about 4. I'll just say one other thing, which is that we continue to get folks filling out the survey, and we hope to continue to update the map as we get more information. And with that, I'll pass it back to you, Jen.
Yeah, I just wanted to, well, as we said, we'll have the link sent out. This is meant to be an interactive experience. If we had the map open, you'd be able to kind of click on things in your region and learn more about each team as you click on each team. And so we'll be continuing to kind of optimize that. But I mean, I think ideally, I don't think we should be mapping these systems separately. I think where the BHASO regions are how we've chosen as a state to kind of organize our systems. And I think it's critically important that we start talking and thinking regionally and figuring out what is the ecosystem around the crisis services that are there. What do we need? What's not there anymore? What do we need that we currently don't have? And start kind of prioritizing places where we clearly have service area deserts, and ensure that we have collaboration and training across the systems, so that we can really meet the needs of all people in behavioral health crisis and also provide follow-up. And so there's a lot to do, a lot of work to do, but I feel like hopefully this gives you a bit of a sense between these two presentations of what we currently have as a starting point in our state. Thank you so much for your attention.
Thank you so much, Jen and Reed. I do have a couple of questions from CRIS committee members in the chat. So let me just fire away here. Did you ask respondents what percent of behavioral health related 911 calls are able to be referred to a co-responder team?
We did not ask that question, but I know that we hope to send out another survey. And so I think that's something great for us to consider putting out there, if that's something that we think programs are able to answer.
I mean, I think another great question is that what percentage, well, it says we're not surveying dispatchers here, but it's given the 100% close to 100% participation rates, there's a lot of really important questions I think we can be asking these folks in a follow-up survey.
So there's an opportunity there.
Oh, yeah.
And along those lines, and maybe this is a question for the future, but how are they screening and making the decision to use a co-response team versus a police response?
Kim, do you want to answer that one?
You know, we have a CRIS committee member, Chief Harding, that runs a co-response program from Poulsbo Police Department. I hate to put him on the spot, but you know, Chief, this is very much a part of your day-to-day life. Would you mind answering that question?
I mean, a lot of times the information that's collected is through dispatch, and that is not always apparent what the need is. So we send out, if we think it could be DHI or mental health related, we'll send out our team to handle that call, and the outcome is often determined by what they find when they get there. Adam, you may be able to talk about that more, because I think, you know, 911 dispatchers are another source of vital information in terms of trying to break down percentages. But it's not always known at the time. It depends on what the call taker is hearing and the information they're given. So I don't know if that answered your question.
Adam, do you have anything you want to add there?
No, I agree with Chief Harding. You know, the dispatchers, probably, well, the first one when it comes through 911, they're the first one to touch the event, and their decision making and what information they get is key to what gets sent out. How police respond, how fast they respond, whether it's a co-response team. So the big thing is there are not that many. When you looked at the map, we wish we had more co-response teams, because so many of the 911 centers, there is no co-response team option. So they don't have that, and they would love to have that. So yeah, so it's important to bring 911 into that when that discussion happens. So.
And this is actually nicely kind of connecting to the discussion we'll have after I give you all a short break, where we're going to be asking what more information would be helpful to you, or what do you need to have that discussion in March about the role of co-response teams. So thank you for taking us there a little bit. I have a couple more in the chat, and then I'll go to, I have a few hands raised as well. Do we have any information on how co-responder programs are funded typically?
We do. We actually have the graphic that we're working on right now that shows how much funding and the wide diversity of funding sources that fund co-response across the state. So it's anything from fire and police departments funding to counties, city governments. There's legislative funding through WASPEC, the Washington Association of Cities. BHASOs have some funding, but it's a limited amount. So it's a very diverse funding stream. Part of the challenge is, I want to just really say that collectively these teams conservatively have served over 60,000 people with behavioral health crisis last year. And that's a very large number of people. And what we hear from our interviews on the ground, our key informant interviews, is this is nowhere near approaching addressing the need. And obviously with a map like what you saw, where there's many places where there are no co-response teams, that we have a lot of work to do, a lot of unmet need out there. And this is kind of how we're responding largely to behavioral health crisis, because we don't have, adequate capacity around mobile crisis for them to work hand in hand. I mean, honestly, when you talk to them about the collaborations, the co-responder programs, they say there's not much collaboration because there aren't teams that they can mobile crisis teams right now that are reliably there for them to collaborate with and hand off to. So that just kind of gives you a sense of the work that's out there and the need.
And I think next question might have come in before the slide came up. The question was, do we know how many people usually per team? And I think that slide said an average of 8 FTE, but it varies, right? Yeah.
And I just really want to emphasize the thing about that I did not know when I started this work was this piece about, obviously a lot of the people that are seen in the field have complex healthcare needs and behavioral health needs. And I think what is very exciting to me is to think about how do we, given the limited resources we know we have around crisis stabilization, and it is just such an inadequate response to be taking people to emergency departments again and again to basically just be sent home. like, how do we serve some of these needs in the field? And that we need people like nurses, paramedics, et cetera, to be engaged more in these flexible, complex models so that we can be meeting more of those needs where people are at without having to have them jump through all the hurdles that we know are there.
Okay, I'm gonna go over to Kim and then take some more questions in the chat. Kim?
Thank you. This is Kim with Disability Rights Washington. Thank you, Reed and Jennifer. This was fascinating. Like, I can't tell you how much I appreciate this information. As background, the True Blood case funded through grant programs about 5 co-responder models, different models, between 2018 until just recently. And my question sort of relates to that variation. When we funded those, each program was like hugely different and developed differently, staffed differently. Some were ride along, some, the way they set up their response services. So I guess my first question is, are you able to look at the variation in how these teams are set up? Because I imagine almost everyone is a little bit different. And relatedly, are there sort of like best practices or sort of most efficient models that are being developed? My second question has to do with outcomes, because we really struggled with those programs to measure outcomes and to demonstrate like the negative. So this program prevented this person from being arrested. How do you measure that? This program prevented an ER visit. How do you measure that? And we really honestly never got that. We were never really successful.
Awesome. Thanks for asking those questions. So related to the outcomes, we asked the programs in the survey what data they're currently collecting. And so we could work towards this idea of trying to help standardize in the future how people are measuring impact, how these teams are measuring impact. So that is definitely a longer term agenda, but we have some limited information about that just from the survey in terms of what metrics are currently being collected. And then, I'm sorry, Kim, what was your other question? Kimberly, what was your other question?
The extent that you've been able to kind of figure out the different models and if you can categorize that, because I assume there's a lot of variation in how these specific programs are set up.
Yeah, I mean, every region right now is very, because the funding isn't standardized and frankly, there's huge disparities even in terms of how these are funded regionally and differences. Everybody's standing up what they need the most. It seems like that's what it seems to me. And a lot of these, by the way, the definition that we don't have in our definition is that all these programs are 24/7, the co-response programs. In fact, most of them are not. Most of them are really functioning more like 9 to 5, maybe Monday through Friday, Monday through Saturday. And I think that's really a limitation of the funding that's out there and the fact that we don't have standardized funding, but we do have that information that captures what you're asking for, yes. And
Could
by
I
the way,
jump in on that
we could
question,
get it.
Jim?
Yeah, sorry. Go ahead, Kim.
Sorry, and hi, Kim. It's great to see you here, and I appreciate the question. One of the motivations for CROA to approach the UW to engage in an evaluation was our hope that best practices could be identified. I can speak as the board chair for the Co-Responder Outreach Alliance. We are frustrated that there's so much that operates under the heading of co-response without any sort of shared best practices in place. So certainly it's our hope by partnering with the UW, not by June, but if our partnership can extend for another year, that we can come up with some lists of best practices to mimic what SAMHSA has come up for the field of mobile crisis. It's a really important goal. So thanks for bringing that up.
That actually segues really well to a question that came in from Dylan, which is, are all the surveyed programs self-identified as co-response programs? Are there perhaps other co-responder models out there that aren't calling themselves co-response? What's your take on that, Jen?
Well, when we sent out the survey, we sent out that definition, and we asked people to self-define themselves, whether they consider themselves co-response. And frankly, a lot of these teams actually refer to themselves as something different because we haven't had a standard definition. And like some, for example, might refer to themselves as mobile integrated health is another term that's used. And so it's just so interesting how the language that you use kind of influences how people perceive the service. That's obviously providing a very critical need right now.
And then Kashi has her hand up. Kashi?
Thank you. We're going to get more time to talk about this in March, right? I'm going to
Yes,
okay,
yes,
I'm going
I
to
promise.
make this really quick then, because we're trying to have a massive conversation in a short amount of time with questions. But Jen, thank you for this, and Reed, thank you for this work and this information. I think I have been wanting to learn and understand more and not come in with sort of preconceived notions. I'm curious about if there's, speaking of outcome measures, and I apologize if you can hear the world's most dramatic dog in the background. I'm curious from an outcome measure standpoint, if there are any takeaways in terms of people who have actually utilized or received response. And I don't know if there's any way to compare the care you receive when you get a mobile crisis response versus a co-response model. And maybe this is just a longer question we can talk about offline, but I think I'm still worried, and we can talk about this in March maybe, about who gets what response. Seems to be really rife with bias to me. Who gets 911, who gets co-response, who gets mobile crisis response, and I maintain a high level of concern about that. And I appreciate your point that both of these models are necessary. We need to arrange an array of things. I think that's a question I've been struggling with. So I just wanted to put those two things out there, and thank you for this work.
May I jump in for a sec, Jen? Kashi, I really appreciate you raising that, and those are exactly the kind of topics that we want to tackle in March. We want to create the space to do that. A big motivation to having Dr. Stuber present her research today was to provide you with the sort of factual background that can then inform the conversation. Shortly, we'll take a quick break and then we'll come back. And one of the big questions I'm going to be asking all of you is, after hearing all of this today, what else do you feel like you need to know or learn more about, so we can start diving into this question, recognizing that we don't want perfect to be the enemy of the good. So Dr. Stuber, anything to add to that? Sorry to interrupt.
Well, I just want to say, Kashi, thank you for saying that. That's exactly what needs to happen on a regional basis. We need to be figuring out, like, well, first off, people initiate the response that they get, right, by calling 911 or 988, and that's something that we need to provide that education about. If you want a 988 and make clear alternatives where there's opportunity for collaboration, I think is the goal. Ultimately, this has to really get planned. And with the ecosystem really has to be, fully developed, and people need to be partnering, and more resources are needed, I think, kind of universally, but clearly in some places more than others.
Okay, I don't see any other questions. I do want to give Representative Orwell an opportunity to say a few words about her vision. But before we do that, I want to extend tremendous gratitude to Dr. Stuber and to Reed Klein for presenting your research today, sharing this with us. This was clearly very valued by our CRIS committee members to hear this information. And thank you for all the work you're doing. We look forward to seeing more of the outcomes of your ongoing data analysis and research. And now I'm going to turn it over to Representative Orwell.
Well, thank you. And a very interesting CRIS committee. These are great presentations, and it really shows the complexity of our system. And again, this incredible opportunity we have to kind of reshape it. And so there is, a couple of pieces of legislation. And I think when we spoke, that I thought I could kind of give maybe just a high level view of one of the bills I'm working on around the 988 rapid response teams, if that's helpful. It sounds like next month we'll have that chance to really talk in more detail. Is that sound okay?
That sounds perfect.
Okay, I'm kind of a visual person, so I have a couple graphs, if you don't mind. It's just easier for me if I could share those, if it'll allow me. I'm very low tech here, but I will try. Okay. Again, I think we're trying to kind of figure out that next step. And one of the things I will tell you is trying to find that path of how we're enhancing the system, how we're having a clinical response for 988, and how we're also tapping in the feed, right? And so the bill I'm working on, which is House Bill 1134, is trying to do some of that work, which builds on all the conversations that you're having here. So I'm going to try to share my screen. Let's see if that will let me share. So, I think there's all the conversations and are trying to understand how 988 and 911 will work together are really important. And again, it's always emphasizing that we know that the majority of calls are resolved on the phone, right? It's a clinical intervention. We know our friends at 911 are more of a dispatch model and are getting that rapid response. So the question is, when we're looking at that 5% of calls, we know some may go to 911. There's a weapon, active suicide. But we know that 4%, like, how do we begin to have a clinical response that's an alternative to the police? And, you know, I think what's helpful about what you heard today is there's this big system of crisis, the mobile crisis teams, and the co-responder teams. And I think what we're trying to do on the 988 bill is say, how do we begin to create a clinical rapid response to that small number of 988 calls, which would be both that are on part of the tribal rapid response line, as well as the 3 call centers we have. So you'll see that one box that's starting to define what those could look like. And again, we see that, you know, as a non-police response, and not that there's not coordination and a close working relationship. We see behavioral health and mental health professionals being part of that team, people with lived experience. I think the bill uses the term certified peers, and that you have to have ability to transport, which again could be a relationship with an agency, van, it could be EMS, it could be fire. So that's the first chart. So now I'm going to dig into the rapid response teams and some of our initial thoughts. So I'm going to go to screen share again. I'm going to stop sharing this. And I'm going to share this. I'm sorry, it's not sharing it better. So when we were looking at the teams, so, you know, I know there's this great work. We got to get all these federal dollars. We need to fund all of our mobile response teams and really enhance those. But right now, that's like an hour, 2-hour response time. And we know if we're truly on the 988 calls going to be an alternative to the police, it really needs to be within 20 or 30 minutes, especially in urban, suburban areas. So this, in the bill is proposing an opt-in model that you could apply to kind of create one of these rapid response teams. And again, it could be an enhanced mobile team. It could be a partnership between behavioral health and EMS and fire. And that 988 would be dispatching this team. They would be, you know, tracking the timelines. They would be seeing what the outcomes are. And they would be documenting and sending that to the healthcare authority, who then would provide an enhanced rate. So we're trying to figure out how we, you know, hone in on a small number of calls, how we have a clinical response, and how we strategically use the 988 fee in a way that ties to 988 calls. And so this is kind of what's being proposed and looked at, is this type of model as an approach that we could do it. And again, as an opt-in model, you know, it might start in different parts of the state and it'll be reported back and we'll learn, did that work? Did that not work? What additional resources are needed? I know I've been working with Vicki Lowe and the tribes, and 30% of the dollars will be for the tribes to also have their own rapid response teams to the Native and Strong line, which I'm excited about. So again, I think part of it is, you know, can we create kind of the framework and then see how each region can create the partnerships to really have a 988 rapid response team. And again, I think it'll look different in different parts of the state.
Thank you, Representative Orwell. And I think this is going to be a really good intro to the conversations we're planning to have next month. So appreciate you getting that started. And we're going to, you know, save that for next month. I do want to make sure we have time to talk about what folks need to prepare for that conversation. And I also owed you a little stretch break about 25 minutes ago. So how about we take a 5-minute stretch break? And then we're going to come back. I don't have anyone signed up for public comment, so I have an extra 10 minutes to work with. So hopefully we'll have enough to cover that conversation, but we also may have a little homework thinking for you to do to get back to us. So let's take a 5-minute break. If I could ask everyone to be back on camera at 5:15, we'll dive into our discussion. And thank you again, everyone who presented. That was great information. See you at 5:15. Oops. Welcome back. I'm going to give folks a moment to come back and turn on their cameras. I know 5 minutes is not very long after 2 hours. Okay, so the plan here is to use the remainder of our time together to prepare for our meeting in March, when we're going to do a deeper dive into what the composition of co-response teams should be. So what I'm asking you a couple of questions, and I'll also put them in the chat so you can refer to them. And do we have the chat? Do we have the questions? I apologize, I'm forgetting. I've looked at these slides multiple times, but do we have the questions in the slides? Yes, thank you. That was very smart of you. Thank you for doing that. So I'd like to, and you can feel free to answer any or all of them, but I'd like everyone to think about what we've heard today. And I want to hear from you. What are your observations about the information presented? What additional information do you as a CRIS member need to inform HCA's work plan to expand mobile crisis services? And in particular, to talk about co-response next month. And then finally, recognizing that we may never have perfect data, how do we continue to move this crisis response improvement strategy forward, even when we don't always have full information? And I recognize that folks are going to have different perspectives on that, but that's why we have a CRIS committee. So let's go ahead and get started. I also have a few follow-up notes in the chat that I'll take a look at. I think most of those are related to our last discussion. So if we don't get a chance to get all of those, I'll make sure that we refer them to our presenters and get back to you later. All right, let's start with Claudia. Claudia, what's your reaction to these questions?
So I think that the information presented was really good, but I'm familiar with some of the teams. When you utilize the map, you're unable to go today. And I know what type of team is that one, for example, Watcom versus the ones that we have in Vancouver. Really, the duties and what they do is absolutely different. And like, to me, the concern, some people work like they have a specific caseload, like familiar faces or grace. People get into the program, so there is crisis response, but it's not the crisis response that we're looking at in terms of mobile crisis. So really breaking down and understanding what are the function of the teams and really what they do, because they are very different. And so I think that we look at them, maybe they are doing crisis response, but they're doing crisis response sometimes to the caseload they hold, the specific number of members who they are providing assistance with, because they are high utilizers, because they're coming into use often. So it's a little bit, I think that I would like to see more granular information in terms of who they serve and what are they doing specifically as a co-responders.
So Claudia, I just want to make sure that I caught all that, because those are a lot of really good thoughts. So I'm hearing that your observation is that there's a lot of different compositions of crisis response teams and different ways that they approach it. And you would like to have more granular information about how different crisis teams are responding, how they might be responding because of the nature of their particular caseloads, et cetera. Did I track that right?
Yeah.
Okay. Yeah. Excellent. Thank you for that. So that's an answer to the question. Let's see. Here's a question also from one of our CRIS committee members about what would be helpful to know in advance of our conversations. What best practices exist out there about the ratio of co-response to mobile crisis response? I'll give folks a little time to process and think about these 3 questions. Thank you for getting us started, Claudia. Darcy.
So I pretty exciting to see the initial work that's being done, and I agree that there's a lot of room for some standardization and guidelines. But we also need to make sure that we have room in the guidelines for local variation or population variation, depending on what the needs are of the area that the mobile crisis unit serves or the co-response team serves. So a couple other things just come to my mind is that knowing that we have a pretty bad workforce shortage in behavioral health, what are the plans to help to support the workforce that's going to be needed to for all these additional services? And then the other question that I just continue to wonder if it's a data or, there still is a population that there will be a true emergency, right? That really co-response or mobile outreach, the person is, truly in an emergency situation, and maybe they don't have a weapon, but maybe they're just really in need of a trip to, honestly, the ER. And so I don't know that we have any real good understanding of where that people that are in that situation, where they fit into this response.
So I'm hearing a couple of things, Darcy, that I want to make sure I track. So one I'm hearing is, given the reality of our workforce crisis, how does that maybe affect our thinking, or how should we factor that into our thinking about crisis response teams? And I take that to mean like now, and then maybe there's an ideal future state, but given our reality now. And then the other question you asked is recognizing the reality that there are going to be people who maybe need, I'm implying from your question, but maybe correct me if I have this wrong, a law enforcement response. How does that work? How do you make sure that that's still possible without some of the risks that are involved there?
Yeah, well, I don't even know if it's law enforcement, but there are people that need like an immediate response.
Okay.
And I don't know that it needs to be law enforcement, but right, it has to be something right away. And and I'm not sure sort of where that fits into the strategy.
Okay, forgive my misunderstanding then. So it sounds like you meant rather than like the 1 hour response time, like how do we factor in folks who need someone right there in a very short amount? Okay. All right. Let's see. I have a question or a comment in the chat. Let me open that up. Okay, similar question. How do we address workforce capacity while looking at expansion of teams? So similar question to what, from Michael reading from what Darcy raised. And I also want to acknowledge something that I've seen a couple of times in the chat from folks. And I think maybe some folks aren't ready to start having this conversation. Maybe this is someone we discuss. It should be something we discuss next month, but some folks are really wrestling with putting co-response in the category of mobile crisis response. That there may be people who feel very differently about mobile crisis response or versus law enforcement, even in co-response. And some of our CRIS members are really wrestling with that themselves, and also wrestling with how we tackle that as a group. And I will acknowledge that I am also wrestling with that as your facilitator, and thinking about how we approach that in a thoughtful and candid way next month. Let's take Michael and then Kim. Michael? Oh, Michael, you're still on mute there. There you go.
Sorry, is that better?
Yes, I can hear you.
Yeah, no, just what you said struck two thoughts in my mind that I would appreciate sharing them. I took notes on Rep. Orwell's presentation, and I appreciate the time frame responsing, but I also, even more so appreciate the time frame envisioning forward. So like my comment about workforce, I think we have a great opportunity here to think about how we want to try to achieve those kind of time frames within the future time, like 2025, 26, 27, and really work with our communities all across the state. I think we have a huge opportunity to work with our universities, our young people in schools, and to really talk about the value of human service, of helping others, of community response, and helping people in crisis. I mean, it's a passion of mine. I've always done it for many, many years of my whole career. So I just think there's an opportunity to stand up and speak this mission out loud, so that we could impact a workforce for the future. I've been part of so many workforce conversations that are great ideas that none of it's going to change now, but we have to invest in the future. So we could kind of philosophize that for a long time, but how do we put that into action? My second thought is that the co-responder piece. I agree. I wrestle with like how does that fit in with the co-responder piece, but I also think again there's an opportunity to think about how they work together in concert for community response when there is a crisis moment. I think to do that, there needs to be a bit more oversight over the co-responder piece, because I see, especially in King County, they're happening in many different agencies on their own, standing up. Again, great resource for the communities, but how we oversee that as a collective piece to have a more unified response to the community. So I think there's many opportunities, but I think we need to start somewhere in order to impact that.
Thank you, Michael. And I'm taking from what you said also that there are some barriers or challenges we need to overcome, but we can look at those as opportunities to move forward. And so I appreciate your thoughts there. We'll go with Kim, followed by Kimberly, followed by Representative Orwell. Kim.
Am I Kim?
Which Kim? Yeah.
We'll go with Kim M, and then we'll go with Kim H. So Kim M first.
Thank you. That'll work going forward too. You can just call us by our last names. So what you said, Jamie, really resonated with me. I am struggling with this notion of how we can draw on co-responders in the expansion of crisis response. And I think what would be helpful to know more about is when and why those co-responder teams are being used. Is it because there's a dearth of mobile crisis response that can respond quickly, and the co-responder model has sort of popped up because it's going to be more quick and flexible? And is there a way of ensuring that the mobile crisis response could just provide that, time frame and flexibility? Where are the real need for something that would involve law enforcement versus co-responder has sort of popped up to fill some gaps and maybe do a great job of that, but I guess it's drawing from you the larger question of how much are we trying to really proactively move law enforcement out of this crisis response, which for me is a lot of this. I want to do that, but I'm not sure the committee is falling there. But better understanding why a co-responder team is filling in there versus mobile crisis response would be very helpful for me.
Thanks, Kim. Yeah, I'm hearing a few themes here, and I'm reflecting about also what Dr. Stuber said at the beginning of her presentation about the different models of crisis response. So you raised the question specifically about law enforcement and their involvement in crisis response. You raised the question of wanting to understand why we are having this. Is it a lack of capacity? Are there other reasons? That would be helpful for us to hear, to have this discussion. So I will make note of that. This is good information to gather in advance of our conversation next month. Kim H.
Thank you. My comments will flow pretty nicely from the other Kims, and we'll speak to number 2 about additional information. I think that this committee has done an outstanding job in hearing from people with lived experience about what they've experienced with our crisis system, and that certainly helped me a lot as a member. I think we also might benefit from hearing directly from crisis workers about their experience in the field. They have a perspective that hasn't been heard by this group yet, and I can tell you as a program manager, it's so much more impactful to hear from a social worker about a day spent with the Bellevue Fire Cares team. I see Rep. Orwell is shaking her head. That is so much more impactful than getting some numbers on a piece of paper about how many people are on a team. So I would strongly encourage an invitation to go out with people that are doing crisis work in the field, not simply co-responders, but folks that work on mobile crisis teams, peers, DCRs. I'd like to hear more about from people in the field when they respond to things. What are the gaps that they see? How would they like to work together with other parts of the system? I think it would be very helpful. I also think that we are still very focused on police-based co-response. I understand, but I think it's at our detriment. The exciting thing that I'm seeing from my position here in Poulsbo is the growth of mobile integrated health and community paramedicine, and the pairing of nurses and social workers in the field all over South King County, and the use of, paramedics all over the western part of the state to help people with medication management. There's just so much potential out there with fire and EMS through co-response, mobile integrated health, and community paramedicine. Was delighted to hear Jen encourage you all to think about co-response in that context. But again, could we get a paramedic on to talk about how he works or she works with a nurse in the field? I think it would be very beneficial. Last comment in terms of direct voices, as you all know better than I do, we're not the first state to wrestle with this. There are jurisdictions that have come quite a long way in figuring out how co-response and mobile crisis can and should work together, from the dispatch point to the field-based point to the follow-up point. Would just request, could we hear from somebody from Arizona? Could we hear from somebody from Texas? Let's go to a jurisdiction that's really thought through how mobile crisis response and co-response complement each other, and how their systems are working in other places as a way to inspire our efforts here. Thank you very much.
Thanks, Kim H. And I'm hearing a couple of thoughts there that I just want to process. So Claudia had said one thing that would be really helpful is to have a better understanding of how different crisis response teams work, what are their different compositions. And Kim, I'm hearing you suggest that it might be helpful in answering that question to hear from folks who are actually out in the field. So that's something, and I saw that also in the chat from you, Kim, so thank you for that. I also do want to remind everyone, this conversation is about preparing us to dive in. I know that a lot of you are wrestling with, your perspectives on this and how we marry those together as a CRIS team that I think has a lot of respect for each other, but maybe is coming at this from different places. So please don't feel under pressure to have that conversation today. What we really want to do is set ourselves up for that conversation next month, and probably beyond that, because this doesn't feel like something we're necessarily going to resolve in a 3-hour meeting. Representative Orwell, and then I see a couple of questions or feedback in the chat here. Representative Orwell.
Yes, thank you. And, one of the things we might want to consider for the conversation next month is, we're creating potentially a new model, and to not use old terminology. And I know the co-responder model, often people do associate with law enforcement. It can be triggering. And so I think it's really helpful when we break down, well, who's on the team, what role do they play, and try to maybe, that's why I use the 988 rapid response team. I was trying to come up with new terminology that would allow us to kind of create what we think it should look like. So that's just one suggestion for the group. The other thing that's come up is around, like, how is 911 and 988 going to coordinate? And one of the things in my bill is to allow the fee so that a small number of 988 folks can co-locate with some of the larger 911 centers. And we think this is going to be helpful to create the protocols to figure out how they do work together. So again, maybe that can be part of our bigger conversation of I think co-location, training, and those other pieces that are going to help our system work together. Thanks.
So beyond the composition of the actual crisis teams, the composition of who's responding to calls and triaging, it sounds like. Okay. Chief Harding. Looks like you might still, oh, there we go.
There we go. What I was going to say is some consideration may need to be given to how to educate people on when they're making a call, because a lot of times people just see behavior. And for example, business owners see someone that they feel is detracting from having customers come in their store, and they most of the time are going to call 911, not 988. So to eliminate law enforcement from responding to those kind of situations where it's someone experiencing homelessness, and their business owner may not want them in front of their store, that's going to result in a law enforcement response if 911 is the resource that's called. And the other consideration there is for a business owner who, for them, that's a very real impact. They don't want to wait an hour, and they won't. So they'll call 911, which is why we respond most of the time knowing what the issues will be. And we make a co-response with our social worker who can help connect that person to services and provide the kind of introduction into services that I think we're talking about. So I think to separate law enforcement completely out, we'll need to really give some consideration to the needs of the people who are making the initial call. Because sometimes it's very clear and sometimes it will just be, hey, I want you to come deal with this problem as they perceive it.
So Chief Harding, that it sounds like that's illuminating also some of the answer to the question of how different teams get sent out, or how this works after the call comes in. So thank you for sharing that. I'm checking the chat here. Let's see, funding issues need to be discussed, and we can talk through that from HCA. So this is from Carrie Waterland. One of the things that would be useful to know is some of those questions that were raised actually during Dr. Stuber's presentation about the mix of funding, which I understand is very diverse across the state. Let's see, it would be helpful to know the difference between how co-responder teams that are based out of fire departments versus those based with police departments operate. Are there differences? How do those differences play out? So that's another piece. Let's see. Okay, that covers the questions in the chat. Other thoughts? Oh, I see Bipasha's hand up. Bipasha?
Okay, I have a lot of thoughts. So Jamie, please tell me to be quiet if it's going off topic, because I've done that to you in the past meeting. Okay, so I just wanted to say, Chief Harding, when you said it depends on who makes the call, the truth is, I feel like 911 has become the call all for everything. You know, like sometimes if I'm driving across 520, which I live, and I've seen sometimes people, you know, on rare occasions over the 30 some years I've lived here, someone walking on the side of the bridge, I don't know who to call. If I see a car stalled in the middle of the bridge, I don't know who else to call. I just call 911 saying someone stalled, do they need help, you know? I think part of this is the education once the 988 system folds out, to educate people, because people don't know who to call, so they call 911, you know, and that's me. I work on a crisis line and I still at times don't know who to call. I just want to take a step back. I feel like it's been 18 months and we've been doing this thing of what data is there and what data gap is there. I feel like, you know, obviously for whatever reason, Washington did a very regional kind of work. And so we don't have centralized data. It just sounds like we just don't. So it's important to collect whatever data we do have, but at some point, where do we say, okay, we're done collecting data, and now we're going to use this data to really plan out the system? And I don't know, you know, and the hope that going forward, we will start having more centralized data just in the future, and there will be a need in the future to change aspects of the system, and that we'll have better centralized data, even for regional programs. I don't see why we can't have centralized data, at least, you know, through HCA and DOH from regional programs. And then there's three words we use very often today: co-response, mobile crisis response, and rapid response. And then we learned that within co-response, there are so many models. And then we know that mobile crisis, different regions have different response, and some don't even have mobile crisis response. And then Rep. Orwell is envisioning the rapid response, which is right now a broad idea. But I honestly am thinking from the perspective of my clients who call, it's very confusing not to figure out what to ask for. And honestly, because we don't have centralized information, I will be honest, even us who are answering the phones, and I have a supervisor who's a mental health care professional, we often don't know. So this is a question I've been asking from the beginning: who is holding the vision to this whole process of what's the data we have? When do we stop with waiting for data? When do we start building out? How do we start making this more funneled, at least in the terminologies we use, rather than having more fractured concepts of, now there's rapid response in addition to mobile crisis response, in addition to co-response. So, okay, now I'll be quiet. Sorry.
I always appreciate what you say, Vipasha. And just to kind of recap what I heard, you were certainly diving into that third question that we asked about how we move forward when the data is imperfect. And I'm hearing you say there's a point where we have to say, this is what we have, and now we need to move forward with planning the system. I think we're still kind of trying to understand what that point is. That's what I heard from you, but it seems like we have something we can work with to start to get a picture of the story. The other big takeaway I took from what you said, and I think I've taken this from a number of CRIS committee members, is that the words really matter, and it would be really helpful to get clarity on terms and definitions and what we mean by crisis response, mobile response, co-responders, rapid response. So those feel like concrete things that I think we can potentially work on in advance of our conversation in March, because no matter what, no matter how folks are using it out there, it would be really helpful for us to be all singing from the same sheet of music in terms of our vocabulary. So thank you for raising those issues. I see Puck's hand up, and then I've got a couple more comments in the chat.
Yeah, Vipasha was talking about, hi, I'm Puck. I'm one of your lived experience folks. I use they pronouns. Vipasha was talking about the words, and I think that that's something that I'm getting stuck on too, because I heard Matt talking about the mobile crisis response and then the designated crisis response being above that maybe, and like, where does co-response fit into that? And so I think on one hand, we're trying to wrap our brains around that, and if we want to encompass all these things under this 988 umbrella. But on the other hand, I'm hearing this thing about like 911 call, maybe we send out a social worker. Like, are we talking about completely eliminating or reclassifying co-response that exists within that currently? Are we talking about sending dispatch over, like dispatching mobile crisis response or core responders or whoever through or in conjunction with 911? Like, I don't want to eliminate co-response under other agencies if they're not also accessing these same behavioral health crisis response resources that 988 is, right? So like, on one hand, I think it is important to categorize all this and figure out where it goes and what it's called, but also I don't want this kind of streamlining to lose people's aspects to less carceral responses if they call 911 just because they didn't call 988.
Thanks for raising those Puck. So there's a few things I heard there too. And forgive me if I misunderstood, but I think I was linking what I was hearing from you with something, maybe it was that Kimberly H said earlier about needing to leave some room for regional or tailored response, that it can't all be so centralized that we lose some of the features that really help people. So forgive me if I did I catch that right, Puck?
I mean, there is that, but there's also like different agencies doing different things, and I want everyone to be saturated under 988. I want all the needs to be met there, but I also don't want that to mean the needs aren't met if they call 911.
Okay, that's really helpful. Thank you for sharing that. And I appreciate you reiterating that message. And also, I appreciate, this also led me to think that having some more clarity on the different models for how people are served, I'll just say that instead of getting us caught in some of the term soup that we've been using today, how people are served sounds like be really helpful for people to understand before we dive into this conversation in March. So thank you for that. I'm going to pause and take a look at the chat because I got a few questions in from folks, from CRIS committee members in the chat. What consistency is there in training lived experience members of co-response teams in trauma-informed care and anti-racism? And then some feedback on the question regarding data. How do we move forward? And the response is we listen. We listen to the experience of those have attempted to use 988.
Jamie, this is Kashi.
Excuse me, it's law
Thank you.
enforcement. I apologize, Kashi. That yeah, it's funny. I was reading that. I was thinking that doesn't sound quite right, but it must be something that I beyond my area of expertise. So thank you for clarifying. Yes, that makes more sense. I'm going to read that one again. What consistency is there in training law enforcement members of co-response teams in trauma-informed care and anti-racism? Thanks, Kashi. That's what happens when you read stuff too fast. All right, other feedback on these questions? So we have a little homework for you as well. Chloe, can you advance the slide? Okay. If you could do some thinking, and it would be great to hear back from you soon because March is going to creep up on us very quickly. I know we dove into this topic today, but if you could do some more thinking about what information do you as a CRIS member need to make recommendations about the role of co-responder teams. I'm using those words co-responder, recognizing that many of you have said today that we're not totally clear on what these things mean. So let's assume that our conversation next month is about the role of about the composition of mobile crisis teams, including whether there's a role and what that looks like for law enforcement or for fire response or for EMT. And then what additional information do you as a CRIS member need to make recommendations around youth crisis response services needed? And we will send these questions out as a follow-up in your email, so you'll have them with Nicola. I think, can we give folks like a timeline to answer these questions so we can prepare for the March meeting? We'll do that in the email that we follow up.
That sounds great, Jamie.
Okay, so I'm going to ask CRIS committee members to give those some thought and then send those back to us. We'll do, you know, the best that we can to be responsive to what you've contributed as your needs to be able to have this conversation. I also may be reaching out to some of you just to prepare for and talk about and get your take in advance of that meeting, because I appreciate that we've had 18 months together and a lot of good relationship building. I also appreciate that we've been doing all of our meetings digitally. We have not been together in real life. Many of you have no idea what anything below my neck looks like. So I recognize that the quality of engagement, particularly on tricky topics where we're coming with different perspectives, can be challenging in a digital setting. And so we want to do everything we can to make this a really thoughtful, candid, and productive conversation. So I will be reaching out to some of you, but please also feel free to reach out to me if you have thoughts on that. I really want to hear your feedback in advance. And Marie and Kim M, we will be following up also just to do our orientations with you in advance of that meeting too, so you feel fully comfortable with working with this whole team. Betsy, I saw you go off mute there. Did you want to jump in and offer any thoughts?
Well, I decided against it, Jamie. I wanted to caveat. Now I'm going to go back and say what I was going to say. In terms of information that folks would be helpful to have the conversation about youth services, I think we owe people more information about what youth services consist of. So, and this is in the interest of extending our work together. As Jamie mentioned, we're simultaneously creating a different calendar to add the year. So I'm going to say, please do contribute thoughts about what information you need to understand, to have a deeper conversation about youth services. And our goal is to bring you a presentation about youth services in Washington, similar to what we did today on, the adult services. So that's a little muddled, but we're trying to run both streams simultaneously and figure out how we can attend with enough detail and deeply enough to youth services.
So maybe I'll just reiterate and make sure everyone is clear. We are optimistic that we will be able to focus March's meeting on the role of co-response based on how we talked about it today in mobile crisis teams, and optimistic that we will have an opportunity to do this same model where we have presentations and information that is provided to you on youth crisis response, and then a follow-up conversation on that. So we're asking you for your homework from this meeting to focus on that first question that we offered you, which again, we'll send out. Not co-response and youth together. Exactly right, Sherry. So we'll ask you to focus on that first question. What other information that we did not yet discuss today, or data or whatever, do you need as a CRIS committee member to be able to engage in that conversation? And also, if you have any thoughts about how to engage in that conversation candidly, but with the sensitivity that is due, please feel free to reach out to me as your facilitator. I want to do everything I can to make that a really successful conversation.
And Jamie, if I think I know that I was muddled in my kind of offering here, but if you have thoughts about youth services, please also offer your thoughts, and that will help us to prep in whatever way we are able to that conversation. So not taking it off the table, but not recognizing that we can't focus in the same way that we can't ask you to go as deeply because we really didn't get to youth services, youth and adolescent services.
And in the meantime, we have some big takeaways from this conversation that we just had, getting more granular and more detailed about different ways that mobile crisis teams or risk crisis response happen. My poor brain is just blanking all of a sudden, but I promise you I retained everything that we talked about today, and we have notes. Oh, yes, getting really clear on the terms that we're going to be using in this conversation. So laying out each of the terms and having a definition so that we can all adhere to in our conversations, even if they're not the way they're necessarily used out there, just so we can all be singing from the same sheet of music. Those are some examples of the kinds of things that we want to prepare in advance of our meeting next month. Any final questions or comments from the CRIS before we do action items and next steps? Dylan.
Yeah, I mean, obviously these are really big topics, and something that I I'm one person representing like sort of a larger community from one agency, and I am posing these questions to other folks in my agency so to be able to collect that. And so I'm not sure if that's going to work out for everyone, but it's something I'd like to share.
Dylan, thank you for raising that, because CRIS committee members are representing different stakeholder groups, and so I really appreciate you sourcing feedback from other folks in your constituency and your colleagues. And if others are able to do that in advance of the March meeting, I encourage you to do that. So you're not feeling like you're one lone voice there, but really connect with other colleagues and constituents. That would be a great way to prepare for this conversation. And we'll do our best to also get the agenda pulled together sooner, so that if there are prompt questions that I'm asking you to think about in advance, that you have those soon enough that you might be able to connect with your colleagues. All right, so action items and next steps. We have some electronic versions of these presentations to get out to you. You should expect an email, I think, from Nicola with the homework question and a timeline for when we'd like to hear back from you. Marie and Kim M will be reaching out to you about some follow-up orientation conversations. Nicola, did I miss any action items?
I think that covers it, Jamie.
Okay, well, you actually get a tiny few minutes back. Thank you, everyone, for hanging. I know the 3 to 6 hours are really tough for folks. I know a few of you had to also get in the car and participate while you were moving kids around. So thank you for that. But as ever, it is a privilege to be working with all of you, and I'm grateful for everyone renewing, in Kashi's words, renewing your commitment to this work in 2023. Also want to echo Kashi's words early on about how particularly grateful I am to the people with lived experience who are joining us today and every time and look forward to seeing you next month. Thanks, everybody. Take care. Have a good evening.